3, 2, over to you.
Bore good morning. May I in the first instance apologise for the late start of today's board meeting. We've had some technical issues. On to the meeting proper. Bore a croeso I cyfarfod bwrdd iechyd prifysgol Cwm Taf Morgannwg. Hoffwn I estyn croeso cynnes I bawb sy'n gwylio heddiw. Good morning and welcome to the Cwm Taf Morgannwg University Health Board meeting. I'd like to extend a warm welcome to all who may be observing the meeting today. Due to the continuing restrictions in respect of public gatherings and essential travel, we are broadcasting today's meeting of the board live, providing an opportunity for anyone with internet access to observe in real time using a link that was shared via various channels prior to the meeting. I would like to therefore extend a welcome to all who may be observing the meeting today. In relation to today's proceedings, I'd like to note the following. For those observing, I just wanted to advise that we may not always be looking at the camera, as we are also referring to our board meeting papers throughout the meeting. We will also be taking a very short break at an appropriate time during the meeting, after about an hour around 11 o'clock, and possibly again at 12 o'clock, depending on the timings. And for board members, as you will be aware, questions on the consent agenda have been sought in advance of the meeting. I have been advised that on this occasion, there have been no questions raised on the consent agenda prior to this meeting. I would like to start the meeting by saying that it is with great sympathy that we offer our Health Board's condolences to the family of Councillor Philip White at the very sad news of his passing. Councillor White served as one of our independent board members for just under 2 years, from November 2019. Prior to becoming an independent member, Phil was also an associate board member from December 2018. He will be fondly remembered by all his friends and colleagues at Cwm Taf Morgannwg University Health Board. Our thoughts are with Phil's family, close colleagues and friends at this very difficult time. I would like to welcome Linda Thomas to her first public board meeting. Linda was appointed as our new independent member for corporate business and commenced in post during October this year. I would also like to welcome Cheryl Davis, Deputy of Head of Nursing, to the meeting today. Cheryl is here to present the patient story which relates to a staff member's journey following him becoming unwell with COVID symptoms in October 2020 and his subsequent admission to hospital and the treatment received. Cheryl will be joined by Gary, the staff member who the story relates to. I note that Sharon O'Brien, Catherine Roberts and Deborah Matthews will be attending the meeting from 11:30 onwards to take part in the discussion regarding the Prince Charles Hospital Improvement Programme, which is on the agenda, item 7.3. I would like to welcome Lauren Edwards to the meeting. Lauren is the new Deputy Director of Therapies and Health Science and is attending on behalf of Fiona Jenkins, who has tendered her apologies. I would like to welcome colleagues from the Community Health Council to the meeting, including Kathy Moss and John Beecher. Jane Sadgrove, our Vice Chair, has expressed a wish to thank Val Wilson, Director of Midwifery, Gynecology and Sexual Health, publicly at board for the leadership she has shown and the contributions she has made to the Maternity and Neonates Improvement Programme. I don't believe Val is attending the meeting today, but Jane thought it was important to make this acknowledgement. To give you advance notice, at the end of today's meeting, I will be asking colleagues how you think we have done. There are a number of questions set out at the bottom of today's agenda that are there to act as a prompt for us all to consider as we work through the items for discussion today. I encourage all members to keep this in mind and offer reflections and suggestions at the end of the meeting to ensure we are working effectively as a board. I'm also asking all chairs of committees to adopt the same approach after each committee meeting of the board. I go on to apologies for today. We had apologies from Fiona Jenkins, Dilys Jubenat, James Heer and Lisa Curtis Jones. Go on to the next item with declarations of interest. We have not been notified of any declarations of interest prior to this meeting. I just want to check, we were going to go into the patient story. Do I change to a different agenda because of the technical problem, or can I go on to that item?
Yes,
please, Emrys, if you could rejiggle the agenda and we will come back to the patient story when Cheryl's able to join us. Thank you.
Okay, thank you. If I can go on to item 3 then. To ensure we focus on business critical activity and discussions at this time, we continue to use the consent agenda for this meeting. I am assuming that everyone has read all the papers under the consent section. Are there any issues that anyone wishes to move from the consent agenda to the main agenda for discussion? I therefore propose that all members present are happy to approve and note all items as requested. I'd like to move now on to item number 4. Are there any matters arising not considered on the action log that anybody would like to raise here today? No. If I could go on to item 5 then, please, and go on to 5.1. I invite Patsy Roseblade to present the report on Audit and Risk Committee, which members are being asked to note. Patsy?
Thank you, Chair. Assume, as you've already suggested, that the report has been read. Just a couple of things to point out, really. The Audit Tracker, which is mentioned there, there has been a huge amount of good work done on this, but there is more planned. And the idea of the planned work is to draw the reader's eye to the highest priority outstanding recommendations. So what's most important and has been on the tracker for the longest amount of time will be evident and very clear to the reader at first looking. There was also a discussion on the timescales set for actions that have been agreed with internal and external audit, and I think it's really important to recognise that we have to be realistic in setting those time frames for completion of action and not feel pressure to give an earlier date that then has to be continually moved along. They're the only things I really wanted to point out on this. Emrys, thank you.
Thank you, Patsy. Are there any comments or questions for Patsy in the meeting? No. If I could move on to item 5.2 on the Hosted Bodies Audit and Risk Committee Highlight Report. I again like to invite Patsy Roseblade to present the report, which members are being asked to note.
Okay, so again, just a couple of things. The committee noted the WAST performance that was included in the East Risk Register, and as previously discussed, we've asked that the WAST Patient Safety and Experience Highlight Report is received at the Quality and Safety Committee, so that members both of Quality and Safety and of the Audit Committee are able to triangulate the information from the external WAST report and the internal CTM reports. Just one more quick point, the WISC Standing Financial Instruction Authorisation Limit concern that's listed at the bottom of that report. It was simply a matter of the authorisation limit of healthcare purchases of over £1 million, and there wasn't a clear governance trail of WISC being able to authorise those. As most people will know, in the NHS in Wales, any contract above £1 million has to go to Welsh Government for approval, but in this case it doesn't, and it's perfectly legitimate that it doesn't, and the standing financial instructions have now been updated to reflect the Welsh Government advice on this issue.
Okay, thank you for that, Patsy. Are there any comments or questions for Patsy? No. If I could go on to item 5.3 then, the Mental Health Act Monitoring Committee Highlight Report, and I invite Jane Sagrove to present the report, which members have been asked to note.
Thank you, Chair. As members know, the Mental Health Act Monitoring Committee includes membership from police and local authority partners, and it exists to monitor the use of the Mental Health Act across the Health Board area. In this particular meeting, we received the usual quarterly report and noted an increase in detentions within both the adult and older persons services. We noted that there were risks around staffing pressures, both within the Mental Health Act team and the psychiatry workforce. This is clearly a matter of concern for the committee, but mitigations were outlined in terms of how the services could continue to operate during the winter pressure period. We continue to monitor breaches and errors in application of the Act. There were 35 minor errors which were all rectified within the 14-day time limit as per section 15 of the Mental Health Act. There were more concerningly 2 fundamentally defective errors, and we are continuing to ask for learning to be derived from such errors. The other area of concern was the issue of recruitment of section 12 doctors. This is where a second doctor is required to certify the position on a detention, and a number of actions are planned, but it's a complicated area, and we are also seeking some guidance from corporate governance around sharing of data across NHS Wales, which may help with this. Those are the key points, Chair.
Okay, thank you, Jane. Are there any questions or comments for Jane? No? If I could then go on to item 5.4, the Remuneration and Terms of Services Committee Highlight Report. That comes to me. I present the report for colleagues to note. If anybody has any queries, could you please raise them now? Okay, if I could then move on to item 5.5, the Chief Executive's report, and I invite Paul Mears to present the report, which the board are being asked to note.
Thank you, Chair. So you'll have seen the report in your papers. Just a couple of things I wanted to highlight. First of all, the point on 2.2 regarding elective recovery. As you'll know, there is a big pressure on us as a health board, in common with other health boards in Wales, to look at how we can catch up the backlog of elective work that we have facing us, and we have some significant challenges here in CTM. There was a helpful session earlier this month with the Welsh Government coordinated, looking at planned care recovery, and that was attended by the Minister. I think it was pretty clear from those conversations that there is the expectation that the backlog of work is tackled, and very much a push from the Minister to encourage health boards to think differently about how they approach the challenge, looking at alternative models, different innovations, digital solutions, etc., to try and deal with this significant challenge. Here in CTM, one of the things which we've recognised is that this process, whilst it's been working along, led through the ILG structure, there have been opportunities, I think, to coordinate that in a more effective way across all 3 ILGs. So we've now moved to a model where we have a small central team coordinating our approach to elective recovery to make sure that we're maximising the use of our theatre capacity and our surgeon and anaesthetic capacity across all of our 3 acute sites, and that is already starting to bring up opportunities for collaboration between sites and the ability to use our resources more effectively across our 3 sites. It's still fair to say we've got some significant challenges, particularly within the orthopaedic services in terms of workload that we're trying to catch up, and of course this is being done against the backdrop of also trying to keep up with the large volume of emergency demand that is coming through our hospitals. So it's a complex complex web, if you like, that we're trying to work within here, but I think the approach of trying to manage this across a central team is going to already bring opportunities for greater productivity of the existing resources. Clearly, anything we do in that front around service models, we will be working closely with our trade union colleagues where it might affect staff, and likewise at CHC if there are any changes to service provision on our particular sites. That was the only key point I wanted to draw out from the report, Chair, but happy to take any questions.
Thank you for that, Paul. If there's any questions or comments for Paul, please. No? Okay, can we go on to the next agenda item then, please, which is the Organisational Risk Register. I invite Georgina Galetli to present the report, which members have been asked to review and approve, please.
Many thanks, Chair. So as colleagues will know, we've been receiving the risk register for probably about a year, 18 months now, with a view to migrating to a revised board assurance framework. And we've recently gone through a procurement exercise and secured the services of Good Governance Institute to help us in the development and revision of our board assurance framework, which will take into account all of the outputs from our board development session in October, where we talked about our principal risks and the board's risk appetite. So we will progress that over the coming months and clearly engage with board colleagues as that develops. I'm pleased to inform the board that we've trained just over 250 members of staff in the risk management improvement work, and the awareness sessions are continuing. The demand is high, so we're continuing with those on a monthly basis, and that just shows that everybody's very, very keen to be keeping risk and risk management at the centre of all of the business and decision making within the organisation. The locality groups presented an update on the status of their risks at the board development session, so I don't intend to go over that in detail, but we will continue work on the calibration of those risks and moderation in relation to all of that. In the report, you'll see that the risks have been updated. All of the updates are highlighted in red as usual, and we've updated the targeted intervention programme and timelines, and that's in Appendix 2. I am happy to take any questions on the risk register, and as usual, I will forward and look to my executive colleagues for the specific details on any issues that are raised. Thank you, Chair.
Okay, thank you, Georgina. Any questions or comments? I'll get to call in Patsy Roseblade first, please.
Yeah, just one question, and we have seen this risk register at various committees, hence there only being one question here, and it relates to risk 3826 on page 387 of the 571 bundle, and it is the overcrowding in ED departments. I've got a couple of questions that relate to this. The risk identification doesn't mention the inability for red release being a risk, and therefore the risk to members of our population out in the community. That's one point. And the second point is the change in consequence of the risk. This risk has a consequence level of 5, so extremely serious, and a likelihood level of 4. But the target is a consequence level of 3 with a target of 3. I understand the change in likelihood as a result of the mitigations, but that's a significant change in the consequence of this risk. I don't know if that's an error, an oversight, or if something significantly changes within this risk that changes that consequence score.
Thank you, Patsy. If I may bring Gareth in to answer the specifics around the red release and the implications, but also how it's been risk assessed. But also I just wanted to comment before he does come in, we are working on the target scores and that consequence. I know that's something that we've had a significant debate about in the Audit and Risk Committee around adjusting the likelihood and the consequence. So we are focusing on that, Patsy, just to give you some reassurance. But I can see Gareth's ready to come in if I can pass to him.
If you could respond, Gareth, please.
Yeah, it's just to broadly agree with Patsy's contentions, really. I think the consequences Georgine has described is one that's under review and we can look at again. The point about the red review, I mean, to be honest, red review is one of the primary, the red release, sorry, is one of the primary areas of focus for our ED departments. It's monitored very closely on a weekly basis in conjunction with our WASC colleagues and through our performance review processes. I can reframe the risk to reflect that very easily, and it's a helpful contribution. Thank you, Patsy.
Okay. Thank you, Gareth. Okay, if I could call in Ian, please.
Yeah, thanks, Emrys. I had a similar issue or question rather, as Patsy just asked, and this was risk 3826, and it can also apply to the other one related to overcrowding in EDs as well. What I was asking was, we were due to have an update on that particular risk in October. And I was wondering where we are now with that risk, and similarly with the Teeth Lydiard risk, the 4149. Do we have any current updates relating to both of those?
So there was a detailed report given to Quality and Safety Committee earlier this week on mental health and Teeth Lydiard. So I would hope that would come through the highlight report that Jane may present later. But unfortunately, I can't comment on updates for the other risk that you identified, and I can't quite find the risk that you've given us the number, but if you could just...
That's the overcrowding EDs, the same one that Patsy mentioned earlier on, that Gareth was commenting on. I was wondering if we had an update of the current situation with that.
Yeah, so overcrowding, sorry, Chair, may I respond?
Okay, Gareth, if you could come in, please.
Yeah, so overcrowding within our EDs continues to be a problem, is consistent with across all of Wales and the UK. Our primary site of risk is Prince Charles Hospital, and I'll pick that up in detail in the report around the PCH improvement programme, if I may. I think overall, the position for Wales is challenging as a whole, and I think our position relative to Wales is actually improving, although the absolute numbers are deteriorating. So we don't take any confidence in the fact that our relative position is improving. But what it says, it gives us the kind of the counterbalance of, if we weren't doing the things we are doing, how much worse would it be? I think historically we've probably been one of the worst performing health boards over the course of the last 3 months. AB, Swansea Bay and Betsy Cadwell have deteriorated by comparison, or I'd like to phrase it, we've improved by comparison. But it is probably the primary risk that we hold within our sites is the overcrowding risk. That's a reflection of the non-COVID pressures as much as the COVID activity that's coming in through the doors, and I think reflects all of the conversations we've had previously in. So it remains our primary focus as an operational team to tackle that, and our daily operational teams consider that as part of their everyday working.
Great, thank you, Gareth.
Okay, are there any further questions? No, we've got no further questions then. If I could then go on to item 5.7, please. This is the Targeted Intervention and Specials Measures Progress Report. I invite Richard Morgan-Evans to present the report, which members are being asked to note. Just confirming if Richard is there, please.
Chair, I can see him the call, but I'll just give him an email now.
Okay.
I think, Chair, Rich saying he can't seem to come off mute for some reason. So I don't know whether you want to just move on to another agenda item and see whether we can get Richard back in the room.
Yes, sure. Okay. Can I then move on to the next item, please, which is 5.8, which is the Nurse Staffing Levels Act update report for adult acute following the biannual calculation in June 2021. I invite Greg Dix to present the report, which members are being asked to note.
Thank you very much, Chair and Baradar Pau. Good morning, everyone. Firstly, for new members of the board, apologies for the length of this pack. There is a legal requirement that the board is cited on the detail of our nursing establishments twice a year under this particular act, and following the nursing care acuity audits that we undertake in January and July of each year. And what you have in front of you today is information relating to the audit that took place in June and July of this year. So just a few key messages, if I may, to bring to the board's attention. So just again, for new members, staffing continues to be reviewed 3 times a day at the head of nursing and senior nursing meetings across our sites, and this is to ensure that the appropriate staffing levels are met. And on occasions, regrettably, we do have to move some of our staff to different wards which may be unfamiliar, to ensure that risk is balanced across all of our sites from a nursing perspective. Under the Act 25B, we used to have 30 wards spread across our 3 acutes, designated as general, surgical or medical wards, which is the requirement under 25B of the Act. Pre-pandemic, those 30 wards dipped to 29 wards when one of the wards in PCH was repurposed to a step-down discharge ward. And out of the 29 wards we had during COVID, 21 of those 29 were repurposed. And I have to, again, put on record to our incredible senior nursing teams and our ward managers who worked tirelessly to ensure that our wards were repurposed to the effect where both our COVID and non-COVID patients were being cared for in separate streams and appropriately. So 21 of the 29 wards were repurposed during the first 2 waves of COVID. And to date, we now have 34 wards which fall under the Act 25B, designated as general, surgical and medical wards. Now, during this time, since my last report, there have been temporary increases in nursing establishments across several of our wards, and all of this detail can be found in Appendix B. In light of the changes, as I said, there's been some temporary uplifts, but I'm not recommending to the board today any permanent changes to establishments until we do further work following the audit that will take place in January, which I'll present back to the board next April and May time. So again, lots of information, and apologies for this, and Chair, very happy to take any questions.
Okay, thank you for that, Greg. Are there any comments and questions for Greg? Jane?
Just wanted to note the report. Actually, Greg, it's a very thorough report. It's clearly an important quality and safety issue, and thank you for ensuring that the board is cited on that.
Thank you, Jane.
Okay. Thank you for your report, Greg. I do not see, there's no further questions or comments in respect of your report. Thank you for the work that's being done, and we look forward to the future review in the early part of next year. Thank you. If I could then come back to item 5.7, please, and go on talk as targeted intervention, a special measures progress report. I note that Richard's back with us now. We've got a few IT problems this morning, and Richard will present the report which members have been asked to note. If I could call you in, Richard, please. Okay. Seems we have a we've obviously got a technical.
We've got an
problem
issue,
there.
Chair. Would it be helpful if I just took that item for on Richard's behalf, given his challenges of getting into onto Teams at the moment? Sorry
Sure. No, that's okay. If you could do that, Paul, that would be great. Thank you.
You'll see in the report the update there on the progress around TI, and I think what Rich was just giving an update really was to share with colleagues an update, given that we'd had a session back in October on this where many of the independent members were involved, as well as colleagues from the exec team and the integrated locality groups. We also said that we would take the opportunity to have what we call a showcase session to go into a bit more detail on some of the areas of good practice, because I think what we recognise there's been a lot of great work going on across the organisation in the field of TI. We had a really good session on the 18th where many of the colleagues from across the teams in different parts of the health board were able to give updates on what were going on in their areas, as well as the work on maternity and neonatal as part of the special measures. Rich has included in the paper there the progress against the milestones in each of the areas of our TI focus, and what we wanted to bring to this board was really just an update to share where we've got to on that progress, and obviously if there are any questions that board members wanted to bring to today's meeting, then happy to take those.
Thank you very much for that, Paul. I note that Richard's back in now. Are you? Just to confirm, Richard, are you back in the meeting?
Good morning. Can you hear me?
I can hear you loud and clear.
Nothing that a laptop restart wouldn't sort out. Apologies, I couldn't come off mute.
Okay, and just to confirm, Paul's just given an overview. I'm not sure if you had the opportunity to hear what Paul had to say, but if you could take us through the item again, that might be helpful. Thank you.
Thank you. Yeah, no, I heard most of that. Thank you, Chair, and I think I absolutely concur with that. I think the only thing I'd add is obviously now it's all gearing up for the 20th of December next TI self-assessment session. So we're now in a 4-monthly self-assessment cycle, which I think we agreed over the last few months is probably better to take us forward than every 2 months, but noting that we use the interim period to showcase the good work going on. So the pre-meets are already underway with sort of various sort of SROs and members of the health board, independent members, to make sure that we're all abreast of a lot of things that are going on, a lot of good pieces of work, quality improvement, etc. And I think, as we've been discussing over the last few days, actually, I mean, the trick for us now is to make sure we're packaging all this up in a really nice way and presenting it, because there is a hell of a lot going on across the organisation, a lot of good work, and we're sharing some of the good work of the organisation as well. So December will give another chance to do a self-assessment, but it will also be slightly different. It'll be the first time we're going to self-assess with the special measures side, so with maternity services and neonatal services. And already there's good work with Greg and Sally and Steve Sewell to pull all that good work together to make sure that we can do that then. So yeah, so it's going well. There's been some great progress, and it's just about trying to use these sessions where we do all come together for this dedicated purpose to really showcase what we're doing. And we've got some great feedback from Welsh Government over the last couple of months with this, and I think as we go into next year, into probably a new phase in the new year of our maturity and onward development, so that we continue to capitalise on this good work and show that. So you're happy to take any questions. Otherwise, looking forward to the 20th of December session. Thank you, Chair.
Okay, thank you very much, Richard. I see Jane has a question.
Thank you, Chair, and thank you, Richard. One of the issues for us as independent members is actually triangulating the information that we are given. And I just wanted to say that the 18th of October event actually was a great way of helping us to triangulate. We normally, as we are in this meeting, hearing from our executive colleagues. At the 18th of October meeting, we heard a great diversity of voices, giving us perspectives from our staff across the organisation, and actually enabling us to gain assurance that the progress is actually, and improvement is actually happening across the organisation, and the depth of commitment of our staff to doing the absolute best they can, and that was great to see. So I just wanted to say that.
Thank you, Jane. I have no further comments on this item, but one thing I will say, Richard, just to say thank you very much for giving us that overview, and it is positive to see that we are progressing on this item, and it's good to hear Jane's feedback in respect of that too. Can I suggest then we come back now on to item number 2, please, which is the shared listening and learning item, and let's read the patient story. We'll now receive a presentation from Cheryl Davis, which tells the story of a staff member's journey following him becoming unwell with COVID symptoms in October 2020 and his subsequent admission to hospital and the treatment received. Cheryl is joined by Gary, who the story relates to. We'd like to welcome you, Cheryl, to take the agenda item forward, please.
Thank you, Chair. Good morning, everybody, Board. My name is Cheryl Davis. I'm the lead nurse for unscheduled care of the Prince Charles site. At the time of the presentation, I was the senior nurse for the operating theatres in Prince Charles, and Gary was one of my team leaders. So I'd just like to talk you through Gary's story, how Gary caught COVID and how he's since recovered. So if you can go to the next slide, please. So a little bit about Gary, who's sitting behind me in the background. Gary commenced his role in the operating theatres as a band 2 in November 2004. He then became successful as a team leader position, so he manages a team of staff. We regraded his role to a band 4 position in May 2013. Through his role, Gary members 18 members of staff. He completes their off-duty, health roster, sickness, management, annual leave. He's like a father to them all. He encourages their training and makes sure that everybody's competent to work within the operated theatres. Gary can also work clinically himself in the perioperative setting. Next slide, please. There's some photos of our Gary in action in the office and in the middle when he was working within the COVID intensive care. Next slide, please. Gary sadly became very unwell with COVID symptoms and he tested positive on the 18th of October 2020. Gary was admitted to PCH and was admitted firstly to Ward 3. He became critically unwell and had to be transferred to ITU on the 1st of 11th 2020. As a team and his work family, you can imagine how we all felt. If you can go back a slide, please, sorry. If you can see Gary, how ill he was, and on the other side is Gary's team, who actually helped look after him up on the intensive care to turn him, because he was obviously ventilated at the time. If you go forward to the next slide, this is the theatre team. Before social distancing, if you just want me, this is one of our team meetings before COVID. You can see we're a large team in the theatre. You can see Gary in the spotlight right in the front, and this is one of our team meetings which we held monthly in the recovery area every month. So this is Gary's work family. Gary was discharged home on the 2nd of the 12th 2020. After a few weeks of recovering, Gary, with his normal working ethos, was very keen to return to work. At that time, he agreed and we put an extended phased return. Gary came back in January of this year. Next slide, please. I'm sorry, Gary did try, but he struggled. He struggled with work and he went back off on long-term sick on the 14th of May. This is because he developed further COVID post-complication symptoms. He has accessed the Health Board Wellbeing Service and he has received very good support from Michelle Smalley, our consultant clinical psychologist. Next slide, please. This is Gary's reflection when me and Gary discussed this. He's no recollection of becoming unwell. He admitted it was like a nightmare. It felt very unreal. He had mixed feelings of emotion, scared, fearful, anxious. Gary will explain himself later if anybody would like to ask him how he feels since his journey back to normal fitness, which he still hasn't achieved. Gary is under the care of the dietitian and the occupational therapy department. He's access to wellbeing services, he's having regular counselling, and he's still very much part of the work family, even though he's not in work at the moment. Next slide, please. the wellbeing services, which I know we're all familiar with. The next slide, please. This is Geoffrey Hurley drew these photos of Gary. Geoffrey Hurley is one of our other theatre assistants in theatre, who was off during COVID shielding and kept his mentality well by becoming a drawer. And as you can see, there's some really lovely photos of Gary and Gary's team. And I think Geoffrey did photos nearly everybody in theatre, and he really raised people's spirits, I have to say. Next slide, please. Gary's COVID journey is still impacting on his life every day. Gary's here with me today and he's happy to answer any questions. Thank you.
Thank you very much for that overview of Gary's circumstances, Cheryl. Are there any questions that anybody would like to ask Cheryl or Gary? Yeah, Linda?
Thank you, Emily. Cheryl and Gary, just wanted to say I found that really humbling listening to that. I thought it was amazing and it's brilliant to see a story like that appearing at the board. This is my first board meeting, so thank you for bringing to life what you guys have been doing. I just had one question for Gary. I was wondering, is there anything that could have been done differently, do you think, that would have made your experience any better, that we could sort of make a note of as independent members?
How do you mean now? In
Be looked after.
being looked after?
I think just anything relating to the wellbeing offer or how you were looked after, just if there's anything at all that would have made your experience any better.
I've had a lot of support from ITU, Michelle, the psychologist, which has been brilliant. There's a couple of things that I felt that let me down. Orc Health, I've taken 14 months to get in touch with me. And I had a phone call yesterday to say that they've cancelled my meeting over the phone because the person has gone sick herself. Things, it's a bit slow in reaction to different things. I had a CT scan on my chest and a lung function test in June, and I haven't heard nothing since. My own GP has been trying to push it up and nothing is happening. It could be more support from the medical side of things. I've been told now I've got urine difficulties, but when I asked the other day about when will I hear back from the urine people, and they said between 13 to 16 weeks. So on top of everything I suffer from, my urine is, I got tendinitis, my urine is getting weaker, and I got no, I was hoping to have urine aids, they told me I would have them, but no, I got to wait up to 16 weeks, which is hard when you're trying to push yourself to get better and little obstacles get in the way. The more support from the medical side of things would be great.
Well, thank you for giving us that feedback, Gary. You've obviously been through a very traumatic time during this past year, and it's certainly evident from the presentation that Cheryl's giving us today how things have been for you. And you've also shared with us some of the challenges that you're finding, as you're going through your life today, with the support from your team roundabout, who I picked up from Cheryl. But also, I did note there was a couple of issues you just raised there around occupational health and hearing difficulties and results from your chest, that maybe that's something we can find out more about outside of this meeting for you. And before I go there, I know there's another question want to come in there from Howell, please, if you'd like to come in.
Thank you. Thank you very much for sharing your story there, Gary. Really appreciate that. I just wanted to really just apologise for the experience you've had there in relation to Orc Health, and just give you some assurances that I'll follow that up as Emrys has said on your behalf and come back to you on that if that's okay. But thank you very much for sharing your story with us this morning. And I think Emrys as well, Dom wanted to come in with a comment as well. But thank you, Gary.
Thanks, Emrys. The first thing is Gary, for those that Cheryl, I think, undersold it really, just what a central figure you actually are in Prince Charles, particularly the theatre staff. You were very much looked up to, and one of our sort of main key players in theatres. So it's great to see you again. I think I'm quite shocked just listening to you. You're not the same person that I spoke to a year or so ago. You sound like what you've been through. We can hear it through your own voice. And I was just echoing really what Hal was going to say, which is just an apology to you for the delays you've had in both occupational health, but also in your medical care as well. And it's all right with you, I'll get some more details and I'll chase up and see what I can sort out for you in the background as well. But concern is I worry that you're not the only person who's had those delays. So I need to look into some of those issues a bit more. But thank you for sharing your story today, Gary. It's really good to see you.
Thank you, Dom. Can I confirm, did you hear what I said earlier on when I was speaking? I can see for some reason my thing was on mute. Did you hear what I said to you, Gary, earlier? Did you hear what I said?
Good.
You did?
Oh, yeah.
Sorry, I was just checking because for some reason it's gone on mute, so my apologies if you didn't. But
you good.
Okay, I've got no further questions or comments from any of the board members, but can I just say thank you very much again for sharing us your story. And it is noted about how traumatic it is, and listen to our Dom, our medical director's comments as well about how important you are as a member of the team in where you're working. Is that something also that's to be recognised and acknowledged in in what you've gone through over these last few months? So can I say to both of you, thank you very much for giving up your time to share your experiences, and Gary, particularly for you to say it as it is as to what you've experienced through there. And we will, obviously, we've taken note of some of the issues you've raised, and we will follow those up outside this meeting. Thank you again.
Thank you.
Okay.
Okay, I'm just conscious, may I suggest that we take a 5-minute break now? We're just coming up to 11 o'clock, and then we'll start again the agenda on agenda item number 6. So can I suggest we come back at 11:05, if that's okay with board members? Okay, we'll recommence the meeting again at 11:05. Thank you. Can I confirm with Emma is everybody here in the meeting who should be in the meeting before we start?
I'll just check you.
Thank you. Well, we've certainly had some fun with the IT today, that's for sure.
Now that I'm connected, I thought it's best to stay on.
It looks like everybody is here, Emrys.
Okay, is everybody okay to start the meeting? Yes? Yeah. Okay then, are we ready to start, Mike?
Over to you, Emrys.
Okay, thank you. Welcome back, board members. If I could now go on to item 6, please. Population Health and Partnerships Committee Highlights Report. I invite Jane Sadgrove to present this report, which members are being asked to note. Over to you, Jane, please.
Thank you, Chair. This committee looks at the health board activities primarily from a population health perspective and explores how best we work with public sector and third sector partners to address issues that affect health. You will see from the report that we looked at risk. We also looked at matters relating to obesity and the Healthy Weights programme. We looked at matters relating to housing and homelessness, and also considered the activities of the Regional Partnership Board and the transformation programme that board is running. And those are the matters I'd like to highlight. Thank you.
Okay, thank you, Jane. Are there any comments or questions for Jane, please? No, if I could then go on to item 6.2, which is the Stakeholder Reference Group Highlights Report. I invite Linda Prosser to present this report, which members are being asked to note.
Very briefly, thank you, Chair. We do hold this meeting with some individuals who represent local communities to discuss services and test out developments that we're working on. And you'll see from this report, we do have an alignment issue with the chair and the vice chair, but I'm told, as you can see there, we are seeking a new chair. The existing chair has agreed to carry on, and there are conversations going on with individuals who may be interested in taking up that role. But what I did want to point out from this is that sometimes we talk about issues that the health board wants to bring to, to ask questions about, and sometimes the stakeholder group ask us for things that they'd like to spend time on. And last time we had a really rich issues that affect carers, and I was particularly touched by those young carers who it just reminded us that as we redesign our services and think about our strategies, these are people that we really need to take account of meeting their needs, and we will continue to do that. So that was all I was going to highlight from that report.
Okay, thank you, Linda. Are there any comments or questions for Linda? Yeah, Patsy?
Just very quickly, Linda, and you've half answered this already with your comment about the existing chair continuing. I just want to make sure there's no risk of this group being sidelined because of the difficulties in recruiting a chair and a vice chair. And it's an important group to continue.
Yeah. No, thank you, and we completely agree, and that's why we're taking a more proactive stance to identify and encourage somebody who we might support in a different way to step into that role.
Okay, thank you. Any further questions or comments? No, if we could go on to the next item, 6.3, please, which is the population health update. And I invite Kelechi Noam to present the report, which members have been asked to note. Kelechi.
Thank you, Emrys Borida. I will just make a number of quick comments in relation to the report. So the reports board members have in front of them today addresses two broad areas. So there is an update on COVID, and then there is a population health wider update. So on COVID, I do have to apologize because the report at the time we wrote the report at this point is probably a number of days off now. So what I will try and do is just cover the updates, but try and make it as recent, as relevant as possible. So the report draws attention to the fact that CTM is currently in an anticipated period of increased community infections, although the overall trajectory of the infection continues to be downward. In the past months, the current wave has been driven by infections in 10 to 19-year-olds, although the incidence in this age group has reduced, while infections in under 9s is picking up slightly. Hospitalizations from infections in the community are also on their way down, although current outbreaks complicate the picture and are being monitored and managed carefully. Intensive care admissions also fluctuate, but a spot audit of COVID ICU cases recently underlined the role of comorbidity, as we've come to be used to. The board is asked to note the focus of our COVID vaccination efforts on tackling inequalities in uptake with a focus on ethnicity, pregnancy, and vulnerable populations. I know there is a presentation on vaccination following this, so I won't say any more about that. Those are the key things I wanted to just say in relation to COVID. And in relation to the wider population health update, members will remember that on the 27th of May, the board approved a population health program paper that had 37 individual action areas. These are being led by individual executives across the organization, supported by public health. The board is asked to note progress on that program, more specifically areas like a staff health needs assessment that is now nearing completion, and that will be the basis of our board-wide, organization-wide health promotion policy. Mapping of activities related to CTM as an anchor institution, the multi-agency housing and health alliance that is in development, workshops to commence imminently on development of a data sharing mechanism between housing and health. On the population health management program, we are on course for provision of de-anonymized data to Merthyr Tydfil primary care cluster and anonymized health board data to GP practices for December 2021. As members will note, this is a program that we've been working on for a number of years now, and we've successfully overcome some of the information governance challenges, and we're on course for having that data available next month. Our key concern in this regard remains the immense pressure being faced by primary care colleagues currently, and it is important that we're able to support primary care in terms of translating the intelligence that this work will generate into preventative anticipatory care actions. The Health Board has made detailed contributions to the Regional Partnership Board and the PSB in support of their population and wellbeing needs assessments that they are required to produce by statute. Also to note progress with the CTM funded pre-diabetes pilots that we completed in the South Cannon cluster, as well as a national pre-diabetes program pilots that is starting in Bridgend and Merthyr clusters imminently. An evaluation of our local pilots is of course for completion. On obesity, we've made great progress in this area. That is a significant focus for Clontarf Morgannog, not least with the Welsh Government funding and Health Board match funding that will enable us put in place an integrated level 2, level 3 weight management service for adults from April 2022. In support of the population health program, the Public Health Intelligence team is also working on a set of population health performance baseline calculations and indicators that will enable us account for progress on population health as a health board. And finally, in relation to smoking, the report contains data on the performance of our smoking cessation services. And those are the areas I would just like to draw attention to, Chair, and I'm happy to stop and take any questions at this point. Thank you.
Thank you, Kelechi. Are there any comments or questions for Kelechi? Yeah, Patsy?
Yeah, thanks, Kelechi. Really informative report. Just one very quick question. Is it possible for us to get probably be 2 A4 sides of paper of just a very brief description and a RAG rating of the 37 items that were agreed by the board back in May? Because with the best will in the world, we won't remember them, and it will be good just to keep a sort of a watching brief on how they are progressing. Not that we will need to have lots of detail in it, just this is the action that was agreed, this is the current RAG rating for it.
It is entirely possible to do that, and I shall take forward that action, Patsy. Thank you.
Thank you, Patsy, and thank you for the response, Kelechi. If I could bring in Paul, please.
Thanks, Chair. Just to give a bit of an update also alongside this, because I think it is another enabler to the population health work, is we've also had some very positive conversations recently with the 3 local authorities, which Kelechi has been part of as well. And it's really encouraging, I think, to see how the councils are also very, very supportive of the drive for our organisation to be focusing on population health, and indeed very clear that they have a massive role to play in helping deliver that programme of work. We've agreed with the 3 local authorities 4 strands of work to work on bilaterally with them between as health and local authorities, one of which is reducing health inequalities and particularly focusing on obesity, which Kelechi is leading with Mark Shepherd, the Chief Exec at Bridgend Council. We're also focusing on what we can do jointly between health and social care to look at developing more integrated teams to support the improvements in population health, and linked to that, how we can make sure we are actively sharing more data and information between local authorities and health on that. And finally, the other area which we're going to work on with them is sustainability and the green agenda. And I think all of those underpin what we're trying to achieve as population health organisation, but also highlight that, you know, we can't achieve this ambition on our own. It has to be something we do jointly with other partners and stakeholders. So it's really encouraging, I think, to see both our organisations focus on this, but also the fact that we have really strong support from our local authority colleagues in our pursuit of this agenda locally.
Thank you very much, Paul. Are there any further comments or questions? No. Can I just say thank you, Kelechi, and it's important to note there the May board paper that there will be a RAG rated actions from that of the 37 actions from that meeting, and similarly noting Paul's comments about the multifaceted approach we're taking in response to the population health agenda. It's good to see the progress. Thank you.
Thank you.
If I could then go on to the next item, please, which is 6.4, and it's COVID booster vaccinations presentation. And I invite Kelechi to present the slides which members have been asked to note. And Claire, I believe, is it?
So yes, that's why Claire is here. So Claire, I pass that over to you. Thank you.
Wonderful. Thank you, Kelechi. So a very live update for you in terms of our COVID vaccination programme. Mike, if I can ask you to move the slide on one. So just by way of a reminder, back in Christmas time, when we were setting the aims of our COVID-19 vaccination programme, we approved these 3 aims, which are still valid today, even as we continue to move through the phases. They present us with challenge on a regular basis, but we continue to develop our COVID vaccination programme and really target inequality as we're doing that, looking at where we are having good or bad uptake and what we could do about it. And then we are also constantly looking to make sure that we're balancing our capacity within the system against the need to deliver and the vaccine supply, so that wherever possible, we have a programme which is in balance and can deliver in the timescales that's required. So if I move us on to our current requirements, the next slide. There is a lot going on, and this vaccination programme only becomes more complex with every JCVI announcement. So here in the next 2 slides as well, I'm just trying to give you an overview of what we're being asked to deliver, how we are delivering it, and where we are delivering it. So first and foremost, we need, and we would continue to ask everyone in our communities to come forward to complete their primary course. We don't want to leave anyone behind. And so that's everyone over 18 who wants to. We are encouraging and working to make sure that they come forward and have their COVID vaccination, both first and second doses. We also have had a recommendation from JCVI that in order to complete that primary course for those individuals who are severely immunocompromised, that actually they require a 3rd dose of COVID-19 vaccine. So that is not a booster, it's an additional dose that would complete their primary course. We will then give them a booster in 6 months' time. So that's another group of people who we are identifying and vaccinating. And then we move into the 16 and 17-year-olds who were given their first doses over the summer. And on the 15th of November, so last week, JCVI announced that 16 and 17-year-olds should now be provided with a second dose at an interval of no less than 12 weeks. 12 to 15-year-olds, at the moment, we are only being asked to provide 12 to 15-year-olds with a first dose, and we await JCVI guidance as to whether a second dose will be required, and if so, what would be the interval. And then finally, the boosters. So it was announced in September that we should commence a booster campaign. And at that point, we were asked to vaccinate with a booster everyone over 50 and all those in vulnerable groups, be they as a consequence of underlying ill health or because of where they work. On the 15th of November, JCVI came out with a further recommendation that extended the booster campaign to the over 40s. And we're working through now what that means. One other area that we should be that we need to note at this point, which JCVI made clear on the 15th of November, is that for everyone under 18 who's receiving a vaccine just because of their age, not those who are at risk, but those who are receiving a vaccine because of their age, should wait 12 weeks if they have had a positive COVID test and or positive symptoms of COVID before they receive either a first or a second dose of vaccine. So that's a significant change in the guidance, and it is linked to a very low level, but linked to a low level risk around myocarditis with further doses of vaccine. And so we're working through the implications of that and communicating with everyone who might already have received an appointment, but has previously had COVID and so wouldn't be able to come back for their vaccine at this stage, and we'll be reappointing and rebooking them. So if I move us on to the next slide, please, Mike. Okay, so what we're trying to do is within the programme think of two aspects to our programme. So that's completion of a primary course, and as I've just explained, that's a first and second dose. And for the severely immunocompromised, that means a third dose. And what you can see is on the left-hand side, the various categories of individual, be that on age or illness, that we're looking to vaccinate. And then the middle columns describes how we are currently doing it. So for Leave No One Behind, that's all about walk-ins for us. Anyone in our community can walk into any one of our vaccination centres and get their first and second dose if they're over 18. We also are running specialist allergy clinics, and where necessary, we are making sure that we have mobile teams who are running pop-ups. So, for example, we went into the universities during Freshers Week to try to run some pop-up vaccination clinics to try and catch up with anyone who hasn't received their vaccine. And then the remainder of our primary course vaccination work is run through our community vaccination centres, and you can see there we've got a mixture of walk-in and dedicated clinics depending on what's required. If I move us to the next slide, we then come to our boosters. So the booster campaign, you can see again on the left-hand side, we're looking at the different population groups and then the model by which we're trying to deliver. So for our care home residents and our housebounds, this is all about our teams going to them. So we've been into all of our care homes and we continue to go back around and make sure that anyone who wasn't eligible first time receives their booster in a timely fashion, or someone newly into the home is receiving their vaccine. Our housebound teams, that's a mixture of our district nurses and then our mobile teams. And we're in the process of establishing some drive-through centres that will allow those who are identifying as housebound, in that they don't feel that it's appropriate for them to come to a community vaccination centre, but perhaps are mobile enough to get into a car with the assistance of a family member, that we'll ask them to come to one of our drive-through centres that we're looking to establish. And hopefully that will mean that we can vaccinate more housebound people with our workforce than only being able to go into people's homes. The remainder of our boosters are then through our community vaccination clinics. They're by appointment only. And just by way of reminder, whilst JCVI announced the age categories for boosters, you still have to wait 6 months from your second dose before you become eligible for us to give you a vaccine. And so we work through those time periods in the order in which someone was vaccinated. And on current forecasting, we're looking like our booster campaign will run into March next year as we move through all of the age groups. If I move us on one. Some statistics, which this is always the challenging bit because it really does change dramatically on a daily basis. Just a couple of the headlines. 12 to 15-year-olds, we've now vaccinated with a first dose 61% of our 12 to 15-year-olds. Our 16 and 17-year-olds, we've vaccinated with a first dose 72%. These are really positive and high uptake figures for this age group. And we're leading the way in places in Wales in terms of our communities coming forward. For our boosters, I'm really pleased to say that yesterday we gave our 100,000th booster. We gave that to Ray from Pentra, and he will be featuring in our newsletter. And what that means is that 38% of the people who are eligible for a booster have now received it, bearing in mind that you can still only come forward after that 6-month period. So some of those people within that percentage won't yet be due. So it's a very positive picture in terms of the pace at which we've been able to deliver the boosters, but it does remain very, very challenging. And some of those challenges I've just set out in the final slide for us to consider. If I can move us on, please. So I just wanted to reinforce some of the impact of the announcements from the 15th of November. I did mention it at the beginning, but it is a really significant change and a challenge to communicate for every under 18 who now needs to wait at least 12 weeks post COVID symptom or positive PCR. So that is quite a lot of administrative work and work from our comms team to convey that. And then our 40 and 49-year-olds being added into the campaign. We did a significant amount of vaccination work 6 months ago, and so actually we're going to have a big number of people who have become due over that Christmas period. and that will prove challenging if we are to try to maintain that 6-month interval. In terms of just some of the wider issues, I won't go through every item on the slide. I know you've had these in advance, but we are awaiting from Welsh Government guidance as to what next year looks like. And for next year, I mean next autumn and winter. We are in the process of trying to develop and put our vaccination programme on a more sustainable footing, but the planning assumptions and the thought process around what a booster campaign for next year might look like is still in development. We are inputting into that, and when final guidance comes out, we'll be in a position to create our sustainable vaccination team for next year. I'm going to pause at that point, Emrys, and see if there are any questions, please.
Well, thank you, Claire. Thank you for giving us a comprehensive overview there. Are there any comments or questions from colleagues? I've seen there's a number of comments in the side chat bar, Claire, about congratulating on the amount of work that's been undertaken by the team to get us where we are today, and a big congratulations to Ray from Pentra as well as being a significant number. So I've got there's no further questions there, but significantly the comments are around the hard work that's been undertaken to deliver the progress that we're doing in respect of vaccination. So thank you very much, Claire, and thank you very much, Kelechi.
Thank you. I'll pass the thanks on to the team.
Thank you. Could I go on to item number 7.1, please, which is the Quality and Safety Committee Highlight Report. I'd like to invite Jane Sagrove to present the report, which members have been asked to note.
Thank you, Chair. The Quality and Safety Committee exists to undertake detailed scrutiny of the quality and safety of our services and the experience of patients. This report actually relates to the September meeting of the Quality and Safety Committee, and where appropriate, I'll give a little update on the November position as we met earlier this week. You'll note that there are no matters to escalate to the board on this occasion, but I'll draw attention to a couple of matters within the report. As members know, we have an improvement programme ongoing in the Prince Charles Hospital. At the time of this meeting in September, we had just had an unannounced visit by Healthcare Inspectorate Wales, and the committee heard about the immediate make-safes that needed to be implemented, and I'm pleased to say that considerable progress has been made with those. Earlier in the meeting, Ian Wells raised a question around Tychidiad and the improvement programme ongoing there. This was considered at both the September and November meetings of the Quality and Safety Committee in detail. Again, there's been an unannounced Health Inspectorate Wales visit to that unit, and largely positive immediate feedback, though of course we await the publication of the report. There is a structured improvement programme ongoing in relation to Tychidiad, with cooperation with the specialist services commissioning, and we will continue to monitor that, but good progress is being made. We also heard updates in relation to neonatal services and maternity services. I won't go into detail on those because we have a separate item on the agenda. We also had detailed reports at both meetings regarding the ophthalmology services. Ophthalmology includes many strands of activity, and we are getting increasing clarity and developed plans for each of the strands within ophthalmology, and are receiving detailed progress reports on that. I think those are the key points I'd want to draw out, Chair.
Thank you very much, Jane. Are there any comments or questions for Jane, please? No? Okay, if I could go on to item 7.2, please, which is the Clinical Advisory Highlight Report. And I invite Anne Lewis, Chair of the Clinical Advisory Group, to present the report which members have been asked to note.
So thank you, Chair. So I try and be a little bit positive about things at the moment, but it's obviously a very challenging time for clinical staff across the Health Board. Last month we met to talk about the wellbeing survey results, and we were joined by Claire Wright from the wellbeing team. There's a lot of, as predicted, burnout and issues with stress and problems sleeping, and the wellbeing team have a portfolio of different approaches to help staff, which it was very welcome to hear about from the Clinical Advisory Group. I think our main concern from that meeting was the fact that whilst 20% of the staff did respond to the survey, which is actually huge when you think about the size of the organisation and a great response, we worry about the 80% that didn't, and whether they are actually in fact the employees who are struggling the most and least engaged with getting help with wellbeing. I think we needed to focus a little bit on primary care as one of our particular concerns in terms of wellbeing. I know that as board you're well aware of the demand on primary care at the moment, that morale is generally really low, lower than I've ever known it in my clinical working life. There's no quick fix to helping primary care in terms of there's no way really of rapidly employing more GPs or reducing the current demands, and we're aware of that. But there are a couple of suggestions of things that I think could help, or we think that could help. One is public awareness of the situation in primary care. So what we absolutely don't want to do is to discourage people from coming forward. We're very mindful of the fact that we're seeing a lot of very late presentations of things like cancer as a result of the last 2 years of patients not wanting to go to their GP practices or not wanting to come forward. So we absolutely need to avoid any messaging that discourages people from seeing their GP when they need to. But I do think an understanding of the pressure that primary care are under would be helpful for them, because they're dealing with a lot of negative emotions from patients, from the population, a lot of anger. A perception that GPs, because they're not seeing as many people face to face, are somehow not working as hard as they normally do, and I think that that's a widely held perception in the population. And if we can do anything to allay those opinions and just have a little bit more understanding in our population of the pressure in primary care, I think that would be really helpful. And similarly, a sort of gentle reminder to secondary care that primary care is under a lot of pressure, because I also, whilst we are all under a lot of pressure and demand, I also think that sometimes we don't have a great sort of awareness of how we're working with each other, and we're sometimes sending things to primary care that really we shouldn't be, and so it's just to sort of be reminded to be more mindful of our colleagues. In this month, we talked about workforce, and we were fortunate enough to have Paul and Dom with us. And I know that the board is very aware of a lot of the issues around recruitment and retention of staff. But it was useful just to have those, to talk about those issues as the Clinical Advisory Group. So some of the things highlighted were issues around occupational health, and the delays in checks, and Don was able to reassure us that it's being looked at, that staff who already work in the NHS, and in particular already work within CTM, don't have to go through laborious occupational health checks just to change a job or role that isn't significantly different. We talked about the streamlined recruitment for allied health professionals, and the fact that our allied health professional departments can only recruit from Cardiff University. And this excludes, for example, Welsh people who have trained outside of Wales who wish to return to Wales to work. And it also creates delays and reduces the pool of possible staff recruitment. And Paul reassured us that Fiona Jenkins is already looking at this area. There was a comment about physicians associates, who we acknowledge have been a great addition to our workforce, have been a fantastic resource to a lot of us. But Ash, who's in the one of the AMD roles for workforce, asked if we could have a sort of overview of where they're deployed and what roles they do. And I think he's going to take that forward with Dom and Harold. We talked a little bit about retention of staff, and some of the key areas that are an ongoing concern are things like having opportunity for staff to have career progression, so from band 5 to moving up the ladder to band 6 and 7, to have time within their sort of job plans to be able to develop personally and do training so that they can sort of extend their roles. And also, we have a lot of reliance on fixed term contracts, and whilst we accept that there is a lack of recurrent funding at the moment, and that's partly why, we do lose a lot of talent from this health board by giving fixed term contracts to people who then go and take a substantive post elsewhere. So they were the key messages from the workforce meeting. And there are two other things that clinicians have raised to me that I'd like to just make the board aware of, if that's okay. One is about accommodation on the acute sites. So our acute sites have always been very tight for accommodation. We've never got enough space for offices and things. But that's been compounded by COVID and the fact that now we can't put multiple members of staff within the same offices. But this means that we have services that we are funding that we are not able to deliver, or not able to deliver efficiently, because we haven't got places for these people to work. And that means we're not optimising the existing resources we've got. So there are examples from the Stay Well at Home team, the smoking cessation counsellors, the proposal of a discharge lounge, which would help with hospital flow. But all of these things require increased space, and I understand a funding request for a sort of porter cabin was turned down. And you know, from our perspective, is that why sufficiently? It would be our question to the board. And then my last comment, if I may, is about the boundary change between the RTE, well, the Royal Glam or RTE site and Merthyr Cynon. There are a number of clinicians who don't seem to understand the rationale behind the boundary change and the implications of it. And I think some clear communication would help with a lot of the resentment that's growing about the boundary change on the RTE site in many different groups of clinicians. The boundary change was brought in as a temporary measure for 3 months, and I think it's just rolled on, and that's one of the problems. But it does introduce, I mean, understanding fully why we have a boundary change, which I do, it does introduce some inefficiencies here, which we'd like to highlight. So, for example, the emergency department flow and the emergency department's ability to discharge patients is hampered by the fact that patients who come to us from the boundary area have their secondary care, sort of scheduled outpatient care in Prince Charles Hospital, and that makes it very difficult for ED to access things like our ambulatory care unit. So I think the general ask from clinicians is, can we have some clear communication about the intention about the boundary change and the reasons behind it, so that some of the clinicians who are sort of boiling up with sort of resentment about it understand what it's about. And if if it makes sense as a health board to make that a permanent change, then I think the general feeling on the RTE site is that that would be welcomed. But with that, could we have the resources to manage the extra patients, and could we move their scheduled outpatient care to the RTE site as well to improve efficiency and allow us to therefore manage those patients properly? So yeah, it's another thing we just ask the board to consider, if that's okay. Thank you.
Okay, thank you for your presentation, Anna. And there was certainly 3 broad themes there around communications around the boundary change and the reasons, the accommodation, and lots of the issues you raised around the workforce and their well-being going forward as well. So I think I'm the first person to offer a comment here. I can see it's Gareth, do you want to comment first, please?
Yeah, thanks, Chair. It's just specifically on that last point, Anna. I mean, Anna's raised an issue that we're fully familiar with across the board. I think Anna's really adequately and fairly reflected the RTE position. The decision's been taken on the basis of a balance of risk between the RTE and Merthyr Cunningham position, and both Dom, Greg, and I, and the exec team as a whole, have considered this, given the importance. And Anna has really fairly described the emotive aspect of this. That paper that was considered by exec was worked up and shared with the ILG as well. So the ILG should really be making the rationale behind that really clear. I've also volunteered with Stuart Hackwell, the ILG group director, to come and communicate that to the clinicians as well. Made that offer to him on Tuesday evening. It is an emotive subject and it is difficult, but I'm really clear, and I'm sure that Greg and Dom will be in support, that on a balance of risk, this is the right operational decision for our patients, and it is challenging for colleagues at RTE. So I'll work with Stuart to make sure we do a better job of communicating that to the local teams, who do take up a huge workload on it as a result of this.
Can I just ask, Gareth, if I may, is it likely to be a permanent, or would it not make more sense to make it a permanent thing, so that we can sort of accept that the boundary has changed going forward, and we?
Yeah, it's something I've discussed in principle with Stuart. There are a number of steps, and the IMTP process may be the route towards doing that. So I'm happy to discuss that in principle with Stuart. There's no objection to any kind of option being looked at that helps flow. So I've committed to Stuart that we can consider that. What I don't want people to hear, though, is that that's what we're going to do. It's going to take a huge amount of work to unpick that, to allow us to do it in the longer term. In the short term, the balance of risk suggests it needs to stay. And I take part in communications. I'll work with Stuart to make sure that's improved.
Okay, thank you, Gareth, for your response and the clarity going forward. Can I call Paul in, please?
Yeah, it was just to pick up a couple of comments that Anna made. Yeah, she was right. That I thought that the conversation we had about primary care was really telling, and I think there were a couple of members on the group from primary care who had some pretty challenging experiences to relay to the wider group about how the pressures were impacting on their practice and them personally. Just to also update the board that we have had regular now, every 6 weeks, David Miller and myself have a get together with primary care colleagues, and the last meeting of that was very much focused on what we can do as a health board to try and support primary care. There's quite a lot of practical things. As Anna says, we can't magic up lots more GPs suddenly, but there are some practical things that we can do to try and support, both in terms of comms. So we're doing quite a lot of work with our comms team now on raising awareness of the pressures in primary care and trying to encourage our communities to only access GPs when they really do need them. But there's also quite a lot of sort of behind the scenes infrastructure things that we could be doing to try and support GPs, particularly some of the admin burden that they're wrestling with. So we've got some work going on at the moment with being led by David and Julie and Sarah in the primary care teams as well, to see what we can do to try and alleviate the pressure on our GP colleagues. But Anna's right, we do need to make sure that we don't add to the burden, and there are quite a lot of the points that came up were actually about what can we do to simplify things between primary care and secondary care that mean that we're not shuffling work back and forth between different clinicians, which also is frankly easier for the patient as well. It's not just about the workload management. So yes, very much on our radar, very much something we're working on actively. And the second point was about office accommodation and space. I think we do need to look at this. I think we we have got examples, I think, of quite a lot of space. We've got quite a lot of buildings across our health board, so I don't think it's about a shortage of actual buildings. I think it's about who's in what space in which buildings, and this is always a slightly contentious area. But I think what we need to be making sure is that we're prioritising clinical space for clinical purposes, and there may well be admin back office staff perhaps located in areas that might be more appropriately designated for clinical services. So I think we do need to look at that, so we can pick that up through the ILG colleagues in the sites and make sure that there is a clarity about how we can use our space more effectively.
Okay, thank you very much, Paul. If I could call Dom in, please.
Yeah, thank you for that. Paul's actually made the comments already I was going to make about the comms and the admin in primary care. I suppose the thing I'm concerned about is also the perception, and you were referring to that between primary and secondary care, that but both think the other side aren't working as hard as they are, and that's been driven a lot, I know, by the media and social media particularly as well. We are working on that, and we just need to get that a bit tighter as to how we go and get that message out. It is better now than it was. We've started some communications between the sites, as Paul said, but we need to ramp that up even more. So I'll take that away as a task for me to do and look into. Talk about the resources and the staff models as well. It's a big area there. We set up a task and finish groups of how we can start looking at improving our recruitment where we need, but also then looking at the alternative models, as Anna was referring to, such as the physician's assistants, but also roles that we can't assume that doctors have always had, but really, do they need them? Does it have to be a doctor leading on these things? And we need to have that open discussion. That's not saying we don't need more doctors, we do, but actually we need a broader workforce as well, working together as a much more MDT. And just the boundary issue, I'm just going to touch very, very quickly on you, right? As Gareth says, I think it's probably best thing we do is we'll take that out from here. We'll go back and we can feed back to board in the future when we've had a discussion about what's going on from there. We'll get a clear view, but clearly there are RTE concerns, and I think there's a lot of appreciation of what RTE are doing to help with that at the moment, and the burden that's on there, and we need to improve our communication with that as well. So thanks for raising all those points, Anna, and fully agree with you.
Okay, thank you, Dom. If I could call in Lauren, please.
Thank you, Chair. Hi, Anna, thanks for that summary. So I just wanted to offer a couple of reflections, having joined the meeting for the first time last week, having just joined the organisation as the Deputy Director of Therapies and Health Science. So I joined the meeting and had some follow-up conversations with colleagues afterwards, and just to offer some assurance to the board that it's a very well received meeting, and I think particularly the attendance by senior executive colleagues. The clinicians that I was speaking with afterwards definitely felt listened to, and like you say, Anna, it is a particularly challenging time for our workforce at the minute, so that means a lot. So I think your update offers assurance into the board that it's an effective way of us hearing from clinicians, and that presence of the executive team allows us to make sure that the clinicians are shaping our strategic direction moving forward.
Okay, thank you very much, Lauren. There are no further comments, but hopefully, Anna, thank you for giving us a comprehensive overview of what was discussed at the Clinical Advisory Group. And can I also say we're taking note of those themes of the communications around boundary change, the reasons, the accommodation issues, and the workforce situation that was raised, and some of the issues when primary care execs have agreed to action those post this meeting. So thank you very much. Can I now call on 7.3, which is the quality report, and is to include an update on the Prince Charles Hospital Improvement Programme. I invite Greg Dix and Dom Herford to present the quality report, which members have been asked to note. And there's two aspects to this item. I invite Gareth Robinson to present the Prince Charles Hospital Improvement Programme update, which members have been asked to discuss and note. And Gareth will be joined by Sharon O'Brien, Catherine Roberts and Deborah Matthews in this item. So if I can go to the first part of the report to ask Greg and Dom to present the quality report.
Indeed, thank you very much, Chair. If I may, just wanted to pop a comment in relation to the Clinical Advisory Board, and Anna's and I have had some conversations with it. It's very well represented by our medics, not quite so much by our nurses, and largely because of timings of meetings, and nurses, work different shift patterns. So we are trying to do our best to ensure that the clinical advisory board is more balanced from both the medical and a nursing perspective. Into the quality report then, board members have before them an abridged version of the quality and safety report, and any feedback would be welcome on the content and style. The majority of the quality metrics are generally embedded within the integrated performance report, but felt due to some of our challenges, you know, it would be appropriate at this time to have a separate quality report. So I've just a few things for me that I'd like to highlight before I pass on to colleagues. So in terms of incidents, no reported never events in the latest period, and the new national framework for reporting serious incidents is embedded now, more so across all of our sites. The highest reported incident continues to be slips, trips and falls, and with hotspots through some of our analysis work across several of our elderly care mental health wards. There's quite a bit of detail within the full section of the report which board members can view. That said, our Innovation and Improvement CTM team are actually currently working with some of our challenged wards in relation to a falls reduction programme, and we're also linked into the national work around falls, which has a much wider scope in relation to supporting falls reductions across our community. So lots of activities within falls reduction. Page 3 of the report you have in front of you has an update on our compliance against the National Patient Safety Solutions, and we had a very comprehensive discussion at our quality and safety meeting just this week, and there is some discrepancy, and I apologise for this, in some of the completion due dates within this particular section of the report, which our patient safety team are currently working on. That said, mitigations are in place for the overdue patient safety solutions of which we've yet to gain compliance, and the DU are linked in again to another national piece of work on the process and also the judgment framework on what constitutes compliance or not, as it's evident there are some inconsistencies across health boards. I talked just briefly about falls. The report details some of our challenges around pressure ulcers, and through again some of our scrutiny panels and analysis, we do have a level of concern around pressure ulcers within our community, and certainly some of our patients that have access to our DN, a district nursing service. In fact, just yesterday, our tissue viability nursing lead presented some data to my executive nursing team on pressure ulcer prevalence and incidence, and is working with all of our district nursing teams across the 3 localities in relation to some further work on pressure ulcer reduction from the community. And then just finally from me, if I may, before I hand over to George, who's going to talk through complaints, and Dom, who will talk through medication errors and mortality. Regrettably, we did not achieve the reduction expectations for 4 out of the 5 IP&C surveillance organisms in 2021, although we did actually report fewer cases compared to the previous year. I'm pretty sure COVID had some sort of impact with this, but nevertheless, regrettably, we didn't reach the levels we needed to. I just also needed to finally update the board on some concerns that were raised at the IP&C strategy committee that I chaired beginning of the month, which related to some inconsistency in relation to application of PPE across some of our sites, and really a strengthened input from some of our medical teams to support appropriate PPE and compliance. So, and it was a concern that was raised at the IP&C committee, which we raised at the quality committee, and it's important that the board equally hears this. lots of these issues are being addressed currently under Dom's leadership and the leadership of the ILGs. And on that note, Chair, I'll hand straight to George to take us through some of the complaints. Thank you, George.
Okay, thank you, George. If you could come in, please.
Will do, thank you, Chair. So I'm focusing just on page 3 of the dashboard around concerns or complaints. There was a presentation given to the Quality and Safety Committee back in the summer when the function came over to my portfolio. And in that presentation, we outlined a number of initial areas that we wanted to focus on in improving our response to concerns and also the quality of the concerns that we provide. I also updated the committee that we were initiating an internal audit into concerns. So we have only just received that audit. It has got a number of recommendations in it. We're just checking it for factual accuracy, but it is a genuinely helpful report, giving us some real clear recommendations about the improvements that we can make that will benefit patients and our responses to patients in a timely and in a quality way. So look forward to sharing that in more detail with the Quality and Safety Committee at its next meeting, and also how that's going to further inform our improvement plan. Some main areas that we will be focusing on around the accurate categorisation of concerns when they come into the organisation, and also trying to focus on making sure there's one point of entry into the organisation for anybody who wishes to raise a concern, and fundamentally making sure that when those concerns are raised, we will be really identifying what the complainant wants to achieve by contacting us. It might be more information, it might be a conversation with the clinician, it might be that they want to look for us to change our processes or our quality of service. So we really do need to make sure upfront we are targeting how we're going to respond to the concerns when they come in. We're also going to try and tighten up on our triaging of concerns to make sure that they, at a very early stage, are routed into the most appropriate part of our organisation to investigate the concern and respond effectively. So there's an awful lot of work going on. We are fraught with sickness absence within concerns right across the organisation, the staff who investigate and respond to concerns. But you'll see from the report we are managing to hover around the 70% of achieving the 30-day timescale of responding to concerns, but we are continually looking to improve on that. Then the only other thing I wanted to say, we have recently held a listening and learning forum, and that shares opportunities for where we've dealt with concerns or incidents right across the health board. We're looking to expand that forum, so to make it an open forum, because there's a wealth of information around learning that help inform the improvement of our services. And we're developing a learning framework as well. So Greg, Dom and I and our support staff are pulling together a learning framework that hopefully we'll be able to share early in 2022, which will capture exactly all of the opportunities for learning and how we're going to disseminate that across the organisation. So there was nothing else I really wanted to highlight, Chair, unless happy to take any questions. Otherwise, I'll pass on to Dom for the rest of the quality report.
There's one question, and that's from Ian, please. If Ian could come in, please.
Yeah, thanks, Emrys. This one's for George. I was going to ask George, first of all, I find this a really good way of presenting a lot of information, and it's a good summary, and you wanted feedback on this. I find it a very useful way of actually looking at things. So my question is on the complaints and compliments page. I think it's two of 6, I think. And looking at the main themes from complaints there, I'm trying to understand the second one, which is the communications issues, including attitudes and behaviours. So I'm trying to get my head around why that is the case, why we've got such a relatively large number in that area. Do we know, are these due to cultural issues, workload pressures on staff and so on? For example, has this deteriorated during COVID, or was it better before COVID? Do we know information related to that yet?
So in summary, you'll always find, unfortunately, a high proportion of concerns are attributed to communication issues. And I think that is something that is largely being addressed through training of our clinical colleagues and making sure that we've got some good customer care focus. And that's part of the concerns improvement plan, actually, is trying to make sure that we put some customer care training right up front in induction. So that should help address those. But I think you will find, unfortunately, that communication issues do tend to be a common theme and feature relatively high within the themes of concerns. And that can be for a variety of different reasons, but work pressures clearly is one of them. But yeah, I think if you want us to dig deeper into that and provide further information, by all means I will, and we can provide that information outside of the meeting or through Quality and Safety Committee, if that'd be helpful.
Okay, thanks, George.
If I could call in Lauren, please.
Thanks, Chair. Just to follow up on that, so at a previous organisation in the NHS in England, I had the complaints within my portfolio, and the benchmarking shows that across all of the trusts in England, communication was one of the themes that came out, and the same as in Wales. So it's some assurance really that it's not an issue that's specific to CTM, and I think it's the fact that we're a patient-facing organisation, aren't we, delivering healthcare? But it's sounds like George has got a plan in place in terms of communication and upskilling our workforce.
Okay, thank you for that, Lauren. There are no further comments on this, George and Greg. The only thing I would say is just noting Ian's comment is it might be helpful to do some further work on those areas where those the greatest issues have been identified. Okay, Dom, did you want to come in now, please?
Yeah, I'll come in about bits. I'm just going to tie off that last bit as well about communication. Sadly, the GMC and the NMC, it's the highest reason that someone gets referred to them is because of communication issues. I think there are themes, and there might be pockets of areas where it is worse than others, and that's something that George, Greg and I are working on, learning where those are. We can make targets in those particular areas. The bits that I'm just going to bring to your attention really is on page 4 of the documents, which is just scrolling down trying to find himself, medication incidence and the mortality rates. So as you can see in front of you, there are a number of medication errors. We found we have 279 in the last quarter. This is roughly consistent with how it's been before. That's not to mean to say we should rest on our laurels and say, okay, we've stabilised it. That's still 279 too many. Interestingly, the prescribing errors are around 67, the administration's around 110. We've had a couple of reports in recently, reviews, and actually 2 of them have mentioned medication errors as one thing on there. One of them, it was an area that we had to focus on immediately. And what they've been suggesting, a lot of people, is prescribing guides. We put posters up on the walls about the correct way of prescribing things, and that works to a certain extent for about a week or 2 until people get used to that poster on the wall and they don't see it anymore. So the other things we're looking at are far more effective are things like investments in ward pharmacists who review the charts regularly, feed back to the teams where their errors have been found, and actually just detecting errors and finding out what the problem is. And then the next step also is then a formulary. So in specific areas such as neonates, maternity, or areas that there are well subscribed forms that we've adopted. But also there's an argument for looking now for ward specific. So we have medicine form, we have a surgical formulary on all our boards, on all our wards across the wards. So we're looking at that. There's a huge amount of learning really comes from this, and it's important to pick them up again. Just saying there are themes, there are trends in certain areas, and we need to look at that and break that down and target those areas. So that's a piece of work that we're looking at the moment. Moving on to mortality rates, as you can imagine, our mortality rate is hugely dependent upon the COVID numbers that we've had. And if you look at the graphs that are on this, you can see the clear 2 peaks of the first 2 waves that we had of COVID. The reassuring thing to that, although any rate of mortality is difficult to ever say the word reassuring, but the fact that this peak we have seen increased numbers, but our mortality rate does not reflect the number of admissions that we have had in the past. Now, whether that's to go and say that the vaccination programme is working well, that across the UK now we've got more learning about what the correct way of managing these patients are as time has progressed onwards, They use far more of CPAP rather than ventilation. Things that we were told to start with were the right things to do, and we followed the guidance all the way through. But you'll see this reflected across all health boards and all across the UK, this particular pattern of the graph here for mortality. So we're following the same way. There are other deaths, obviously it's not just COVID that these graphs I'm looking at. They're underlying that, and how much the contribution of our debilitated population who have been shielded is contributing to people being in a more frail, weakened state. And that's increased our mortality rate, are issues that we need to be looking at over time. But we are doing obviously our best, as our teams always are, to reduce our mortality and morbidity in hospitals. So those are the 2 comments on there. I did notice in the middle of that someone had a question up there, so I won't have to Gareth yet. Is there any questions people want?
Yeah, there's a couple of questions. I got one question from Kathy, please, CHC.
Sorry about that, Chair. I was literally just about to send a message because I need to leave for another meeting, unfortunately. My question was for George around the learning framework that you discussed. We regularly have advocacy workshops with the Health Board Concerns team to discuss the process, and we often hear a negative feedback from clients, not around just the complaint issues, but how the complaint was handled. So I think any learning that you're doing as a health board, we'd be really grateful to feed into that so we can share our experiences as advocates and the experiences that the clients are telling us about. Sorry, I was just typing that as I was leaving, so just a very, very quick one for me.
Okay, thank you for that, Kathy. Your comment is noted. Can I bring in Jane then, please?
Thank you. I just wanted to pick up on the medication issues, Dom. And to advise board that at the Quality and Safety meeting on Monday, we actually had updated figures in relation to medication incidents as a result of an independent member query. And in fact, there were 273 medication incidents in the time frame, the most recent time frame, of which 1 caused severe harm, 21 moderate harm, 64 low, and 187 no harm. Just thought it was important to advise the board that that had been picked up and discussed at Quality and Safety, and that we have emphasised the need for care in presentation of data as a result. Oh, and also, sorry, that we have also asked for an in-depth report to the Quality and Safety Committee on medication errors.
Yeah, thanks. Emrys, can I just
quickly come back to that, please?
Sorry, Jane and Rosie both made that comment to me. I did have this written down here to raise that with you, that we have been asked to do this in-depth medication error report for Quality and Safety next time, so we are looking at it at the moment. The other area to mention, obviously, within this is another way of tackling medication is looking at e-prescribing, when you can only prescribe certain amounts, when there's a drop box and you can only select the one that you want, so therefore you can't get the error wrong in terms of the dosage and the route of it, and that's something that we need to start looking at and investing at the moment. That ties up sadly with our e-records program, but that would be certainly the way forward that many people are using to tackle this big issue.
Okay, thank you for that, Dom. And just to note Jane's comment that there'll be a further in-depth review in relation to medication prescribing to come to the Quality and Safety Committee. If I can go on to the next part of that agenda around for Gareth to present the Prince Charles Hospital Improvement Programme.
Yep, thanks, Chair. And as Jane's touched on in the Quality and Safety update, this paper has already been through the Quality and Safety Committee, and it sets out a number of developments since the start of the programme. The first part of the paper describes the governance structure following a recent review where we identified that the governance and assurance mechanisms needed some strengthening. So I set out within the paper the new governance and assurance mechanisms. I won't walk through it in detail here because colleagues have obviously had the opportunity to review and can ask questions if they feel the need, but I wanted to include this as part of your assurance that we have a greater grip on the improvement programme. More than the mechanisms around the reporting, I wanted to focus on some of the key highlights. One of the areas to draw your attention to is the submission to HIW of our response following their initial feedback to us in September with their review, their on-site visit. They've acknowledged our positive response to the findings of their visit, and that the response that we've offered clearly shows our commitment to addressing the issues highlighted. They've also evaluated our response and noted that it's a comprehensive set of actions with some progress already made, and that the response gives the HIW assurance that the Health Board has appropriately considered the issues and responded in a robust and swift way. And I think that's a relatively positive feedback from what was some challenging issues that were raised by HIW. So we're clear that the response that we made has assured the HIW that although there's a huge amount of work to be done, both in the short, medium and long term, that we're heading in the right direction and giving the HIW the assurance that they need to see, and hopefully the board needs to see as well, that we've got the programme up and running in the right way. Section 2.5.1 then walks through some of the transactional actions within ED, and again I won't laboriously work through them, but it's probably worth highlighting a couple of areas. One is the decommissioned trolleys in majors corridors. That was a major area of concern for HIW and for our own staff, and we successfully made those changes. There are some consequential actions which we continue to manage on a day-by-day basis, but that's a really big step forward for the quality care we provide within PCH. And it's also worth noting the focus within the programme on the staff engagement. This was a particular issue highlighted by HIW, with the ED team feeling slightly distant from the leadership teams, and there's been a demonstrable shift and change in the approach to the leadership working with the ED teams that know what the answers are in reality better than probably anybody. Section 2.5.4 summarises the theatres programme. Three things probably worth noting. The immediate risks that were identified at the start of the programme have largely been made. An action plan has been developed that consolidates all of the immediate actions, the IPC audit that triggered the initial look into theatres, and the AXA standards review. And the AXA standards are the benchmark, if you like, of what standards and procedures should be in place within theatres. We've had that review, and the outcomes of those, none are an immediate make safe position, but they've been built into the theatres improvement programme going forwards. We've also completed a review by a number of experts. I was going to say, for want of a better term, but they are experts: lead surgeon, lead anaesthetist, scrub nurse and ODP that have come in from outside Merthyr Cynnon to review the theatre's ways of working. No major concerns are identified, although there are a number of practices that do need updating and evolving, and those are being built into our response. I think the key thing worth highlighting within theatres is we do have a leadership deficit within theatres at the moment. So we've got some complications around sick absence that are contributing to our ability to make rapid action, and the Allergy are coming up with a plan for how to address that in the short term. The paper then walks through the wards and the flow projects. I will canter quickly over those and can take any questions on those, given they're relatively straightforward. The paper really focuses then on priorities at the end, and there's three worth mentioning. The first, I think the programme still needs to lock down our outcome measures. The programme is all about contribution and actions at the moment, and less so about the outcome measures. How do we know that the things we are doing are having the positive impact we need? The programme recognises that, and that is a piece of work that is ongoing in terms of designing, measuring and then reporting the outcome measures that we need to see. That will iterate as we go through our reporting cycles over the coming weeks. We need to finalise the contribution of external partners to provide capacity to help deliver. So we've got lots of contributions coming in from Improvement Cymru and Improvement CTM as well. And it's also highlighting some leadership issues. There have been some changes to the leadership team, not triggered by the HIW visit or anything related to that, but there are still some constraints, as I alluded to, within theatres and at the RG level as well, which we need to address. It's worth concluding by saying that Catherine and Sharon, who are on the call now, and we can get into the detailed questions with Catherine and Sharon here, have led a significant improvement in the way that this programme is tackling some of the legacy issues that we face at PCH. There is a long-term plan. This is a long-term plan. All parties, HIW, anybody involved in the programme recognises that this is not an overnight fix, but I'm confident that the actions that we've needed to take immediately are appropriate and have been progressed, and that the long-term issues that we are addressing through the improvement programme will be resolved, but they will also take time. I'll pause for breath there.
Okay, thank you very much, Gareth. Are there any comments or questions anyone would like to give Gareth or Catherine or Sharon, please? No. Jane, did you want to ask something?
Please. Thank you, Chair, and thank you, Gareth. As I said earlier, we had the opportunity to discuss this paper in detail at the Quality and Safety Committee and to ask quite a lot of questions around it. What the committee wanted me to do actually is to say thank you. To say thank you to staff at all levels and particularly on the ground for their willingness to engage with the programme of change, for the effort and commitment that they are showing in driving it forward. And we are seeing a difference. It is going to be a long journey, but you know, staff are really committed to taking this forward, and that was great to hear and see. Thank you.
Thank you very much, Jane. I'm just checking if there's any other comments here. Now, can I just thank Gareth, Catherine and Sharon, obviously, for a comprehensive overview of the work that's been going on in PCH, and it is very positive too to hear that the externals like HIW are really noting the quality of the actions and the action plan you put in place as an organisation, and also picking up on Jane's comments there, the notes of the Quality and Patient Safety Committee, where they have noted, where they have identified and noted the positive work that's being done in this by the staff up in Prince Charles Hospital. So thank you very much. Sorry, Kath, did you want to say something?
Oh, apologies, Chair. I think we just wanted to say thank you. We sat in the room here and we know how hard everyone's working at this. This is not about treating symptoms, it's about treating the underlying causes. It's going to take time, but the commitment of everyone has been great. And for that feedback to come from Jane, it was it's heartfelt for us here. Thank you.
Thank you very much. Okay, thank you again very much to Jane, Kath and Sharon. Catherine and Sharon. If I could then go on to the next agenda item, please, which is the performance dashboard. Sorry, Gareth, did you want to say something?
No, apologies, Chair. No, I thought I was up next with elective.
Sorry. If I just want to invite Linda Prosser in to present the report, which the board are being asked to note as the performance dashboard. It's also an important point to note that later on the agenda in 8.1, there's further scrutiny of a performance that we will pick up perhaps more in detail at the end in the next on item 8.1. So if I could invite you, Linda, to give your overview, please.
Thank you, Chair. And I, in preparing for this, had intended to cover a lot of ground which has already been covered, and I don't want to repeat that. And in fact, of course, the quality element is a direct duplication. So we've heard about, so this report is the objective representation or manifestation of both the pressures and the activities that have been being undertaken. I must say I did agree with Gareth. I was expecting him to do the planned care recovery programme next, so that I then knew I didn't have to comment on that also. Chair, would you mind if we did that, and then I can?
And I have to say, it's my apologies. I went straight to 7.5 as opposed to 7.4, and that's me moving one step too fast. So my apologies. That if I could come back to 7.4 then, and we talk and the agenda item, the elective care recovery programme. I'd like to invite Gareth Robinson to present the report, which members have been asked to note. Can I also advise members that there are appendices referenced within the report which may not have been included with the agenda pack, but become made available to members upon request. Okay, Gareth, over to you. Thank you.
Thanks, Emrys. And the report is there for all to see. There's a lot of detail in there, but I'll walk through some of the key issues. There's a general update on the first section on the activity against the plan, and there's a number of areas that are worth highlighting. Firstly, we're slightly behind on the inpatient activity, but that's offset by more than offset by this day case activity, and this really reflects the bed pressures that we've been experiencing through the COVID period. So we're able to maximise our day case activity within the capacity that we have available. We've significantly overperformed in the new outpatient category of care, but I think, if I'm being really honest, this reflects a relatively cautious approach to forecasting when we were setting our plan for the year. So while it does appear we're being particularly successful, I think that reflects probably a less than ambitious forecast back at the start of the year, but it's still pleasing to see that performance. And then follow-ups are broadly on plan, supported by the high levels of virtual activity that you see. We'd like to see more virtual activity within the planned care recovery programme, and that is an area of focus for the plan going forwards. As part of the IMTP process, we are re-looking at how we complete our capacity and demand work going into 22-23. Colleagues will recall when we set out the elective care recovery plan at the start of the year, we were coming from a position of blindness in many ways because we weren't clear on what core capacity we would have. We're in a much better position now, understanding the implications of COVID, and that will allow us to plan more effectively going forwards in 22-23 and beyond. It's probably worth highlighting the centralised working group. So the elective care recovery plan had the two aspects to it. What can we do within the core work, and what can we do within the additional resourcing that's been provided by the additional funding that's been provided by Welsh Government. As we've been focusing on the additional funding areas that's brought in WLIs and additional sessions and so on, we've allowed the RGs to focus on their local operational plans. Now has been the right time to pull that into a central team. So we're managing the central coordination of elective activity to make sure we're maximising the critical mass. The aim really is so that if we have theatres team available but not beds in one hospital, that might stand theatre activity down. We might have the opposite effect in another site. So we're trying to manage the resources in a way that maximise the return on all of our valuable and finite resource. There's four things worth highlighting that are coming out of that group. The opening of the Ward 15 is planned now for December the 7th. That will allow us to restart elective orthopaedic activity at the Royal Glamorgan Hospital, but on behalf of Cwmtach Morgwanic patients, so that is a corporate resource, not a local resource. And that's actually tied up with some of the boundary flex issues we were talking about with Anna. The boundary flex allows us to make that change. We're also looking at using the Royal Gwent as ring-fence capacity for orthopaedic work, and that's being led by Steve Saracen, our consultant orthopaedic surgeon in Prince Charles Hospital. We're expanding the ophthalmology work that can be provided at the POW with the second theatre coming on stream in the coming month. And we're also looking at potential centralisation of colorectal surgery at Royal Glamorgan Hospital as part of the overall programme about how we maintain access for all patients to their vital services. And then I'll just set out really, the paper then sets out a lot of updates by work stream, which colleagues can see for themselves, and I won't walk through the detail, but there's probably four things worth just lingering on for a second. We're having a slower than anticipated update on the SOS and PIFI, so that's the see on symptom and patient initiated follow-up outpatient work. So that is an area of additional focus for us going into the Christmas period. We are really pleased to announce that we've had the deployment of a mobile endoscopy unit now scheduled for late January, which will allow us to expand the diagnostic capacity in endoscopy from the start of March. That's been a labour of love for all involved. We've got wellbeing hubs that will start in December or early January. This is about providing in primary care access to services for patients that may otherwise access secondary care, but being seen in a lifestyle and wellness hub. And we're hoping that that's going to care for something like 5,500–6,000 patients through the coming year. And then finally, it's worth highlighting that our outsourcing uptake hasn't been as robust as we'd hoped it to have been. The private sector has not been able to provide the capacity that they planned for at the start of the year, and it's just highlighting that as a risk to the project going forwards. I'll draw breath there and invite questions.
Okay, thank you very much, Gareth. If I could call in Patsy, please.
Yeah, just a comment and a couple of questions, Gareth, please. I'm so pleased to hear about the extra theatre for ophthalmology. I know it's only one of our difficult and challenging areas, but eyesight is so important. So congratulations to everybody involved in that. The questions I have relate to the waiting list payments, and I know it's noted in the report about the difficulty because of the Welsh Government information that came out, but we did discuss this quite a few weeks ago now, and I wonder what the resolution to it was. I'm not looking to put anybody on the spot here, but we were looking for ways around the information around the waiting list payments. And finally, my question is, how realistic is the elective plan, the catch-up plan going forward? Because of course that relates to the financial position, for which I'll want to ask the question later.
Patsy, I was prepared to answer, but Dom's probably chomping at the bit to come in on your WLI question. So could I invite Dom in first, Chair?
Yeah. Okay, Dom.
Hi, yeah, thanks for that, Patsy. It's a difficult one because the Welsh Government have issued exactly what we're allowed to pay for this, and teams at the moment are, to be honest with you, extremely tired and overworked already, picking up so many extra hours. So trying to engage them to do extra work is difficult, and they think they're being paid less than the WLI, and I can understand exactly why is being paid less for doing the work that they've got to do extra on top of everything else. So that's probably quite an impasse. This is not just our health board has this. Every health board in Wales is in the same position discussing it. What we've done to resolve this is the actual definitions are very vague, actually, both in the elective recovery payments and the WLIs. So we've worked on where that areas where WLIs have happened before, they will be carried on. And we basically left the elective recovery team who manage it to work out what is a WLI and what is a pure elective recovery, and work from there and flag those very clearly to the staff. We've taken that to the LNC to understand. We'll be discussing that again at the LNC this week. But that doesn't just apply to doctors. Also, that applies to the nurses and AHPs as well, who will be paid at a higher rate by using the elective recovery programme. So for some people, it works well. It doesn't work quite so well for. So we're working our way through it. Teams are much happier with the position that we have taken now, that we're not just getting rid of all WLIs, and we're also then trying to comply with the Welsh Government requirements. So it's a bit of a difficult field to navigate, but we seem to be finding our way through it at the moment.
Okay, thank you, Dom. Did you want to come back on that, Gareth, before I call Paul in?
Yeah, there's just one change, slight kind of running off at a tangent in a way on that, but it's really relevant. The reason why the recovery plan this year was so heavily focused on WLIs and additional payments and effectively relying on a staff we've already got is because the funding at the start of the year was provided non-recurrently. Colleagues will be aware that a couple of weeks ago, Welsh Government announced £26.1 million worth of recurrent recovery funding into the Health Board for us to plan more effectively. And Linda and Sally and I, as part of the IMTP process, will have a much better ability to support recurrent requirements for additional staff off the back of that. I mean, it won't be enough, let's be clear, but at least it gets us into the discussion in the areas for us to be more sustainable in our responses going forwards.
Thank you, Gareth. Paul?
Thanks, Chair. I just want to pick up Patsy's point about the link between the elective recovery and the financial allocation for this year, because obviously, as Gareth just, there's some recurrent monies, but there are also non-recurrent monies against which we have planned for this year. There is some risk around some of those, partly down to workforce challenges and just operational delivery ability, given some of the winter pressures that we're under. But I think it's fair to say that we are working really hard to try and make sure that we mitigate any of that risk by pushing on with some of the initiatives Gareth just described, in particular the drive to manage some of the activity from across the organisation in a central location. I think that gives us great oversight of what these schemes are and what we're working on. I just also wanted to just highlight, this is a big challenge, and I think depending on which national meeting you go to, the priorities, whether we're 1 minute talking about the priority of elective care and then in another meeting everyone's saying we've got to sort the unscheduled care. Obviously we sit in the middle of this and try to juggle the both. So I think we just need to be really honest and realistic that, you know, this is not going to be easy. There are some real challenges. I think we're doing everything we can do to give ourselves the best chance. I think the other positive thing is the development of the opportunity of potentially delivering some orthopaedic surgery at the Royal Gwent. Members may know that the Royal Gwent is no longer has an emergency A&E function there, so that does mean that capacity is slightly more protected than some of the other acute hospital sites around us. So we are piloting before Christmas a couple of operating lists down there with our surgeons and our theatre team going down and delivering the services in the Gwent. I think if that works, it will actually give us a real opportunity to think about some additional protected capacity for orthopaedics. And it also very much sits well with the national drive for a regional solution around orthopaedic services, which is very much being recommended by Welsh Government colleagues. So I think on lots of levels that opportunity gives us quite an interesting potential to expand our capacity, to give us more theatre and bed capacity to get orthopaedic work done. So really it'd be useful to perhaps give an update on that at the board meeting in January once we've had some experience of the first pilot lists down there.
Okay, thank you for that, Paul. If I could call in Carolyn.
Thank you, Chair. Apologies, I don't think my camera is working. I'll ask my question very quickly. Just to say, Gareth, around the outpatient performance and the DNA, and you mentioned a DNA rate of 10% and the fact that the reminder system was switched off, the text reminder. I note that's due to come back in December. Is that on track? And have you got any feedback on whether the communication plan, which you referred to, is having an impact on DNAs?
Carolyn, I can't give you 100% certainty on that. I'll need to go and check that it is still on plan. I've no reason to think it's not, but I can't give you 100% certainty, so I'll go away and check. The comms plan, we have to be honest, the comms team have wrapped their arms around the recovery programme really well, and there are very clear messages given out through our normal channels around the difficulties that patients will experience in terms of accessing patient care. We have a contact line as well for patients to query what their potential issues and likely waits are going to be. We can't always answer that directly because of the moving feast that COVID recovery is. Our GPs are also properly on the front line of that communication as well, because as you'd expect, patients access those probably more regularly than they would into the acute sites. So the comms team are fully involved in this, and the comms plan is working particularly well. But I will need to go away and check on the text reminder service and just give you a firm answer on that.
That's absolutely fine. Thank you. And just to say, it's really good to see the endoscopy unit coming online. I think there's some great stuff happening, so thank you for that. Thank you.
Thank you. Mel?
Yeah, thank you, Chair. It's just picking up on Paul's issue, and it's the issue of orthopaedics, because I know that Paul and I discussed this about a month back, about some of the issues in orthopaedic surgery, and I'm glad to see that the service has now been centralised, so we're maximising the potential of all our surgeons. Can I just confirm that? So all the surgeons that we have, orthopaedic surgeons, are now operating from either Ward 15 or operating from the Royal Gwent. Is that right, Paul?
So the plan, Mel, it's not quite yet actioned yet. We're just in the planning stages, but it should be happening imminently. Is that once Ward 15 is opened for electives down at Royal Glam, which should be within the next couple of weeks, that will be the location where we'll be looking to do the inpatient operating for orthopaedics. Obviously, bearing in mind there is day case operating in orthopaedics, which can also take place in any of the other sites as well, because obviously it's day case. And the other thing to remind ourselves is that obviously the elective part of orthopaedics is intertwined with the management of trauma. So we will still be making sure that we provide trauma services in each of the sites where there is an A&E, where there's an A&E. So I think that is the plan. As I said, the Gwent is still in the pilot phase, if you like, before Christmas. But hopefully, once that's taken place, then we'll have clarity on where that will go. in the future. I think the other thing just to mention is that we are also using capacity in the private sector under an outsourcing agreement for orthopaedics as well. So we've got a variety of things going on, but yes, the bulk of the orthopaedic inpatient activity will be planned to be at the Gwent. Sorry, at the Royal Glam, and that should hopefully be in situ before Christmas.
Thank you, Paul. And I also support in Patty's comment. I'm glad to see that ophthalmology is seen as a major priority as well, and I totally agree with Patty's comments on that. Thank you,
Mel. Thank you, Mel. If I could invite Jane.
Thank you, Chair. Gareth, that's quality and safety. I raised the issue of diagnostic weights, and because we do have the highest weights in Wales for diagnostic, I think it's important that the board as a whole is aware of that. We have 31% of the waiting lists for diagnostics in Wales. It's great to hear about the mobile endoscopy unit, and clearly that will contribute to reducing those waiting lists. Could you give board an update on where we are more generally, and if there are more things that you need in order to help reduce those waiting lists?
Sure. Thanks, Jane. So off the back of the announcement for the recovery funding, the recurrent recovery funding, that does give us an opportunity with the ILGs to work up detailed plans that bring in permanent solutions. So the difficulty with diagnostics this year was the inability for us to find short-term additional capacity on the basis of only having non-recurrent funding. So that recovery funding allows us to look into the diagnostic aspects in more detail and produce more sustainable options, but that is work that is in progress and currently don't have the ability to report on that. There are two other aspects though that will play into this. The first is asking the ILGs to increase their appetite for outsourcing, and they have had appetite for it. It's just the availability of it, but as the market expands in that kind of area, then we'll have the opportunity to increase our ability to outsource. Fundamentally, the best step though is one that I hope to be able to take in the next week. So we've had revised guidance from Public Health Wales about the social distancing arrangements and the elective pathway, particularly around outpatients and diagnostics. We're expecting to see a proposal brought forward for a revised management of the elective pathway, which means we'll effectively be able to get more patients into the diagnostic areas, which is the crux of the problem for us, is people in a department, which slows down access to diagnostics. If, and it is an if, because the proposal needs to come forward and be reviewed through the usual decision-making processes, if that changes next week, then we would expect to see a significant step up in our diagnostic capacity. I don't think until we complete the capacity and demand modelling that needs to be done over the process of the IMTP, that I'll be in a position to say with any degree of confidence when each mode of diagnostic really has a clear plan on clearing its backlogs.
Thank you, Gareth. If I could call in Paul, please.
Yeah, also just wanted to update also on Jane's question. As Gareth rightly said, there's a number of sort of shorter term, say within the next 12 months or so, plans that we're trying to do to catch up on the diagnostic weights. And of course, we need to remember that the diagnostic weight is an important part of the cancer pathway as well. So it is really critical that we get that sorted. I think we need to recognise a couple of things. First of all, across Wales, there's been a piece of work done by the Imaging Services Group of Radiology, which has highlighted a large number of shortfall, in scanning capacity across Wales. So the number of CT scanners and MRI scanners we have is below where it really needs to be. And of course, that is a massive challenge because, of course, that has a big capital price tag associated with it, which if you want to increase the amount of physical scanning capacity. One of the options we are looking at, and I think we really do need to pursue, is the concept of a community diagnostic centre. There's a lot of drive in England at the moment to look at developing community diagnostic centres where you have a facility in the community that is equipped with scanning capacity, MRI, CT, but also other diagnostic capabilities such as physiology and cardiac pacing, other things like that. And that is the idea that you would be able to pull the non-urgent work that currently goes through our scanners in the hospitals out into another centre, which is going to be much more convenient for the population because it's probably in a more local facility, but also means that GP referred work, non-urgent work, can be sent to that centre. There is a piece of work we're doing at the moment to scope that up and potentially go out and look to see if there's any providers of diagnostic imaging equipment out there who would want to come and work with us on developing that concept. And it's certainly something that I think we should be pursuing quite actively in the next few months, because I think candidly, with the amount of capacity we have in our scanners, taking Gareth's point about the social distancing will give us back some of that capacity, but the stark reality is we don't have enough capacity for the volume of activity we are seeing now. And if you think about the growth in CT and MR as a primary diagnostic for most specialties now, we will need to increase our capacity for scanning. So we do need to think a bit differently about how we do that. So hopefully as we start to evolve those plans, we'll be able to bring something back to the board in the future.
Okay, thank you, Paul. Linda, did you want to come in? Linda Prosser?
No, thank you, Chair, but I think made those comments.
Okay, and there are no further questions in response or comments in respect to what's been presented today. Andrew, thank you for giving us, Gareth, thank you for giving us an overview in relation to the elective care recovery programme. Obviously, there's a lot of actions that we're undertaking within the health board at the moment, and a lot that we need to get an update on, which we can follow on for our next health board meeting. And thank you again, Vivek, for your input and presentation. Okay, if I could then go on to item 7.5, please, which is the performance dashboard. And I invite Linda Prosser to present the report, which the board are being asked to note. And just for confirmation is that I know this is a highlights report, and there's been some further scrutiny in relation to performance, which will be identified through the 8.1 around the Planning, Performance and Finance Committee highlight report later. So if I could call you in, please, then, Linda.
Indeed. My earlier comments, I can be relatively brief here because, as you say, this is a report that is scrutinised in detail at the Planning, Performance and Finance Committee. There's a couple of things I would like to highlight which haven't been mentioned, and then I'd like to just say something about the report itself. Obviously the performance metrics that are represented on page 4 and 5 are, particularly in relation to patient access, are not in the least bit where we would want them to be. They do reflect the October realities, where, as Gareth said, recovery has been really hampered by an unprecedented and unscheduled care demand profile such as has never been seen. I would like to just point out, though, that on page 5 of the report, the quadruple aim 2 box, the very first line shows us that despite all of their pressures, the GP practices really are trying to prioritise access, and in fact we did see an improvement in that period, and I think we should note that that's really important and to be noted. The other aspect which we haven't highlighted so far, and we should notice, is all the way down then on page 28 of the report, which really starkly demonstrates one of the real pressures in the system, which is the increase in the numbers of delays to transfer of care out of hospital, where, and again, not outside of the experience of other health boards in other parts of the UK, really difficult profile of getting people out of hospital who are waiting to go for packages of care in their own home or waiting to go to another bed in the system. Less of a problem around care homes, and just wanted to highlight that we're working really hard with the local authorities on this and currently are looking at all sorts of measures, including shared employment of health and care staff, some purchasing of some step-down care home beds to really protect the secondary care element of our service delivery, particularly being able to protect elective services. I wanted just to say something else, something about the report. Others might have questions on some of that. I mean, I think, again, through PPF, we have incorporated new measures. For instance, with ambulance handover, we include the 15 minutes, which is the actual target, as well as the 1 hour to give us a rounded picture. We've improved, I think, the narrative, but there's still further to go in terms of the data that we present, the optics of it. And I think in particular, some visual representation of our confidence in the actions that be undertaken and the impact that they're going to have. So those are the areas where we're seeking to develop this next. So I'll pause there for questions.
Okay, thank you, Linda. Could I ask Patsy to come in with a question, please?
Thanks, Linda. Thanks, Chair. I've got a question on the ambulance handover bit and question on stroke. So I'll go into the ambulance handover bit first, which I'm sure you'd expect me to. Just to put into context, in the box it says how we're doing, what actions are we taking. It talks about 3,138 lost ambulance hours. To put that into context, that means 130 crews spent the whole of their 12-hour shift in a car park with one patient. Now, I know that was important for that one patient, but for the rest of the patients in our resident population, that's not entirely helpful. And I know you know that, and I know you're trying to work hard to do something about it, but this board is about reiterating things and challenge and scrutiny, and I just feel that we need to do that. The other point I wanted to make on ambulance is to understand, and after the meeting will be fine, but understand what POW are doing to improve their red release rates. I know what PCH are doing, and that's clearly improved a lot, and RGH, but POW is extremely low, worryingly so, and I think at some point we need to understand what their plan is to improve that, whether it's bays, protected bays or whatever, in the same way as they're doing on the other sites, but at some point we need to understand that. And with regards to stroke, I see that the 24-hour performance has improved quite a bit, and a lot of that is due to the additional consultant, but again, it's funded on a 5-day basis. So what I want to know is when we're going to get into 7-day working for stroke, because people don't just have a stroke Monday to Friday, clearly. And also if it's the numbers, as in the narrative, that is causing the huge variation, particularly in the 4-hour wait, so the admission to the stroke unit, if it's the low numbers that are causing the huge variation in percentage figures, then perhaps it will be helpful for us to have the numbers as well as the percentages. Thanks.
Thank you. All noted. We'll take those on board. Thank you.
Okay, thank you for that, Patsy. Can I then ask Ian to come in, please?
Yeah, thanks, Chair. Patsy just said numbers as well as percentages. I think sometimes it's also useful to have percentages as well as numbers. And the one that Patsy talked about, the number of ambulance patient handovers over 1 hour, for example. It's difficult for us to make a comparison from month to month when we just got a number, because we don't know how many of the total, if you know what I mean, that is actually affecting. So I was going to comment on that specific thing. So it's just reiterating really what Patsy said a moment ago. Right, thanks.
Okay, thank you, Ian.
I'll feed that back to the team.
Yeah.
Okay. If I could call Gareth in, please.
Thanks, Jay. So just two quick comments on Patsy's questions, if I may, Chair. The first one around POW. There were three things really worth mentioning around POW. Their recent performance has been really exacerbated by their close geographical proximity to Swansea Bay. So with Morriston regularly being in overwhelmed status and calling business continuity on a number of occasions, we've taken a huge influx of patients from Swansea Bay, which on the day of arrival has the impact on ED as you'd expect, but it then also has massive delays in terms of patients being repatriated back to Swansea Bay. It's not an excuse, it's just a factor in terms of some of the numbers that are contributing to POW's performance. We have two specific plans in place around the things that we can control. One is expanding the potential use of the field hospital. We've got a plan being worked up to expand the patients that can be cared for that are waiting for their domiciliary care within this Betty Saran, which is a fundamental problem within POW. It's more of a backdoor issue than a front door issue in Bridgend. And that will hopefully be coming on stream over the course of the next week, moving from 30 to 40 beds and then coming back for a further decision from Gold on moving to 50 or 60, which will give us more capacity in the system. In terms of stroke, I think it's a really well made comment, Patsy. We do need to move to 7-day working. The increased operational focus on the stroke pathway as part of the day-to-day operational arrangements has had the impact that you're seeing in terms of the 24-hour performance, and that's really good to see. But fundamentally, until we get into the remodel of stroke with the national programme that is the direction of travel for stroke, then we are fundamentally under-resourced as it stands. The recovery fund, and I've probably spent the 26.1 million 4 times over on this in this board meeting alone in terms of where we want to focus that resource, but the 26.1 million comes with a number of conditions, and supporting resource into stroke is one of them. So we expect through the RMTP process to be developing our medium and long-term plans from stroke, tapping into that fund as part of the sustainable answer. So it's not a short-term answer, that's where that operational teams are focusing on a day-to-day basis, but it is a route to improving stroke overall for the patients with CTM.
Okay, thank you very much for that, Gareth. Are there any further comments or questions? No further I can see. Most importantly from that presentation there is to take note of the reporting questions that were raised by colleagues and also the links to those outcomes as well. So thank you very much for that, if you could take that away. If I could go on to the next agenda item, please. Can I just check with colleagues as well? I know we're due a break. Are you happy for me to go through 7.6 before we have the break, or would you like to have the break now? I've not had a response to that, so I assume we can run with happy to go on to the next item then. Okay, so can we go on to 7.6, please, which is the Maternity and Neonates Improvement Programme update. And I invite Greg Dix and Dom Herford to present the report, which members have been asked to note. Steve Sewell, Maternity and Neonates Improvement Programme Director, will also be in attendance for this item and will be on hand to support Greg and Dom with any questions. So over to you, Greg and Dom, please.
Thank you very much, Chair. I'll start off. So just a few key messages really I'd like to bring to the board's attention within the report. So for new board members, IMSOP, the Independent Maternity Services Oversight Panel, published their 5th progress report alongside the stillbirth clinical review report on the 5th of October. What was really pleasing from the progress report from IMSOP, they noted positive progress on our improvements and acknowledged the huge challenges the team have had in relation to maintaining safe service delivery and continual improvements through our COVID wave. So it was really encouraging that IMSOP noted that within their report. Work has begun on the neonatal category clinical review, and IMSOP have yet to formalise the final publication date, and some of the immediate make safe actions are now in place following an initial deep dive of work that the neonatal team from IMSOP undertook earlier in the year. And at this juncture, I'll just pass to Dom, Chair, if I may, just to illuminate a little bit more around the neonatal improvement part of the programme.
Okay, thank you, Dom.
Thanks for that, Greg. It's all right. It's always the case when you try to find the one thing you want when you're talking to someone, it completely vanishes from your view, doesn't it? So look, thank you very much indeed for that. I can't find. Can you bear with me? There we go. That's what I wanted. As Greg sort of pointed out, that there is a lot of progress has actually been made on this already. The issues, sort of the top program risks and issues, you can see on the second slide here, slide four on here, I should say. The neonatal deep dive did actually raise some extra issues that we really need to look into. That obviously since then we've worked on that and escalated that very high, and there is significant improvement on there, which Steve can give you some more details if you actually want on that. But I just want to move to slide 5 really about the neonatal improvement areas. Obviously, when we submitted this was a lot of the reports will say was organised in October or November, and a lot of these are much more complete now than they were. So with the medicines management group, they did approve the SOP for prescribing that's in place. This was, as I alluded to earlier on, when we were talking about prescribing, there were some significant concerns amongst the neonatal prescribing, and this is one of the big areas that we've been working on here. So that having a pharmacist in place and having a formulary in place will significantly reduce our prescribing errors. So that's a big step forward. There is also the documentation of snapshot audit is being completed as we speak. The full analysis has not been done yet, but actually it's been shown that we are significantly further forward than we thought we were, and things are improving there. So there is still, the overall conclusion I'm going to make is that there is still work to be done. There's still progress. Obviously, we're at the start of this process, but actually we are assured that we are on track and are improving things steadily day by day. So I'm going to hand back to Greg if he wants any other comments on maternity, or if you've got any questions, then Steve, Greg, or I can answer.
Thanks very much, Dom. So the neonatal improvement part of the programme is now very much aligned to the maternity part of the programme under the leadership of 2 improvement directors. The original RCOG recommendations from a maternity perspective, there were 70, and the progress report published by IMSOP on October the 5th confirms that the Health Board have now achieved 55 out of the original 70 recommendations, 10 of which will remain under review by IMSOP colleagues, and the remaining 15 are generally focused on our continued leadership development work and culture, which is now formed into several bespoke work packages with associated metrics underneath that. I guess the 55 recommendations that we've achieved, it's been a lot of work in relation to ensuring they're embedded in practice, and largely to an extent were fairly transactional. The maternity part of the programme has now very much moved on to more of a transformational phase. And as part of that work, we are engaging very well with our My Maternity, My Way Women and Families user group in relation to putting together our vision for maternity services for the next 5 years, which aligns to the national vision, which was published probably about just over 2 years ago. That the strategic plan will be that neonates and maternity will have one vision and associated strategy, aligning obviously to the organisational strategy work that's been led under Linda. So lots going on in this space. Very encouraging for IMSOP to produce some, very good plaudits in relation to where we are. We still have a way to go, but kind of 2.5 years into this improvement journey, there's been lots of changes along the way, and I'm incredibly proud of this team. And again, thank you, Chair, for mentioning Val, our Director of Midwifery, who leaves tomorrow. Actually, she has been outstanding in the last 2 years, and we will very much miss her as part of the team. So thank you for that.
Thank you, Greg. Thank you, Dom. I've got Jane wants to come in with a comment.
Thank you, Chair, and thank you, Greg and Dom, for the reports. I think it's always important when we discuss this at board to remember that we're doing this work to ensure that women and families within Cwmtaf Morgannwg get the absolute best services from maternity and neonates. The team's doing an awful lot of improvement based on lessons learned from past experiences. And we are assessing progress through an assurance chain, which starts with the local service groups, but comes up through the Maternity and Neonatal Improvement Board, which I sit on behalf of the board, which receives a considerable amount of detail in terms of activity, changes, plans, etc. From the Maternity and Neonatal Improvement Board, the assurance chain goes up to the Quality and Safety Committee, which discusses things further, and then on to board. What we have here is the report that also came to Quality and Safety Committee. We did have a discussion at Quality and Safety Committee about whether we've got quite enough detail in this report to give all independent members the assurance needed. So we're going to be looking at that again over the coming couple of months. But I would say that from my personal experience in terms of sitting on the improvement board itself, there is an enormous amount of information which actually underpins these reports. And can I just finally, Chair, add my thanks to Val Wilson for her leadership of the maternity aspects of this programme over the last couple of years. It has been remarkable.
Thank you very much for that, Jane.
Chair, could I just come back on that, please? Possible?
Yes, okay, Don.
Just sort of say to James' comment there, that it is a very rigorous process that we're going through, and it'll be a very long, rigorous process as it should be, so that we can assure everyone that we are improving, that we will deliver the very best care that we have got. Val has been instrumental hugely in the maternity side, but we also have people like Jane and Steve who are really leading on the neonate side as well. So we have a real belief amongst the health board that we will become an excellent centre. And it's going to take us a little bit of time to get there, but already we've made the make safe in place that we're happy with the service as it is, but we can always get better. And I don't think we'll ever stop trying to push for that.
Okay, thank you for that, Dom. There are no further comments or questions. Can I say that, you know, noting the comments of where we're at in moving this programme forward, it's really positive to see the good work that is going on within our organisation. I note Jane's comments as well about the work that's gone on and how it's been recognised within the Quality and Patient Safety Committee, but we will probably need to go into more detail in respect of assurance. And a big thank you to Val Wilson, who's done a significant role in leading the work that's been going on in our services. Okay. Can I just go on to the next agenda item then, please, which is number 8.
Hello, Chair, it's me.
Okay, let me just run it. It's Planning, Performance and Finance Committee Highlight Report. I invite Mel Jehu to present the report, which members have been asked to note. Okay,
yes,
Mel.
I'm conscious of time, Chair, so I'll go through it. There's really not a lot. As you say, the report is there for all to read, and this is just a summary of the highlights of the Planning and Performance and Finance Committee, which were held on the 18th of October of this year. And initially, as you'll see from the report, that the only item for escalation was to bring board aware that the month 5 finance report, we had the report, and then we had a verbal update on the month 6 report from the Director of Finance, Sally May, and we noted at that meeting that month 5 and indeed month 6 was reporting an underspend, and I think that's reflected. It'll be reflected in the Director of Finance's report for month 7 as well for this year. However, we were forecasting that we did a break-even report at the end of the performance year. During the course of our committee meeting, as you say, we we looked at many things, including our own committee annual self-assessment review and an improvement plan, which was approved. And then we looked at the winter response planning and noted that although there were no Welsh Government requirements so far for a winter planning process, that Cwmtaf Morgannwg were actually preparing one to address the issues that you would see during the course of the winter months. And we also had a very, very interesting and thorough report on the access to GP practices, which we received, and noted the progress that was being made within the primary care for patients accessing our GP practices within Cwmtaf Morgannwg. And then, of course, as already been highlighted, and we had the scrutiny of the performance dashboard, and as you can see that that's been touched upon during the course of Linda's presentation and the questions we have from some of our PPF members sitting in this board meeting today. And indeed, we'll further scrutinise the performance dashboard in 3 weeks' time when we meet at the PPF committee before the end of the year on the 21st of December. And just looking at, we went through the organisational risk register, and then we had a report on ophthalmology services. Again, I'm not going to develop that because we've had an update on ophthalmology services from Gareth and from Paul in his report today. And finally, we had a report on the CAMS Performance Improvement Programme, and again noted the progress that's been made in that very, very important area of our CAMS provision within Cwmtaf Morgannwg. And unless there are any questions in relation to the content of my report, that's the highlight report, Chair.
Thank you very much, Mel. Are there any comments or questions from colleagues? No, none noted. Can I just say, as you were aware, I was planning to have a break, but I am conscious of time for everybody within this meeting, so we are carrying on with the meeting. Can I now go on to item 8.2, please, which is the Digital and Data Committee Highlight Report. I invite Ian Wells to present the report, which members have been asked to note. Ian.
Yes, thanks, Chair. Digital and Data Committee, this one was held on the 25th of the 11th. It was a very detailed meeting with lots of very important papers presented at that meeting, but I'll focus on a few of them which are very relevant to this particular board meeting. The first one, which is an alert escalate report, was a report to do with the disaggregation of ICT services from Swansea Bay University Health Board. As members will know, when the board was created with Bridgend coming into the old Cwmtaf board, and most of all the services from the Bridgend part were connected with the Swansea Bay, and there was no funding given in order to disaggregate those services. I would like to commend our ICT teams who have been working as part of their day job, effectively, to disaggregate those services over the years since we've actually gone through that merger process. However, I think they're reaching a point now where it's becoming difficult without additional funding, and it started to show in terms of what they can achieve as far as that disaggregation services that the process is concerned. And we are getting to a stage where we find it difficult now to end service level agreements, and also it's affecting services, any ICT services as a result of that. So really we wanted to escalate this one to the board so that they're aware of that position, and potentially put in a request for further funding. I know that is something that's been ongoing, but it is something I think that maybe we need to sort of re-emphasize. So that was the first one, which we wanted to escalate to board level. The second one was we received a very good report on clinical coding, which members will know has been a concern of the board for some time now. But I'd like to sort of state what the current status is and what we're trying to do to sort of resolve this issue. The board failed to meet 98% of coding targets in 2020-21 and remains off course to comply with the standards in 2021-22. There's significant risk to the transformation of coding services presented by inaccurate digitally stored records, And finally, the meta-labeling of documents within this CITO system may be suboptimal, reducing the level of efficiencies that clinicians and others may realise from the adoption of digital records. So there's a number of concerns there within that report. However, that's something that we've been aware of for a little while, and there have been plans put in place to try to improve that position. I'm glad to say now that the plans are starting to reap rewards, but we're not seeing them in the statistics yet. But plans are in place, which I wanted to assure the board for, in terms of recruitment and training up of new coding staff. So there is a positive story to tell, despite some of those statistics. And the last thing I'd like to focus on, there were lots of others as well, but the last thing I'd like to focus in on is we did in the in-committee session have a number of reports on cybersecurity, which I can't go into detail of because they were actually in committee. But I would like to assure the board that there are some very robust plans taking place in terms of cybersecurity to protect the data of our patients within this area. So I'll stop there, and if there's any questions, I'll try to answer them.
Thank you very much, Ian. I know Paul wants to comment on your point, so I can bring Paul in, please.
Yeah, just a couple of points. Absolutely endorse what Ian was saying about the disaggregation of the IT issues with Swansea. Still quite a lot of work to do. The team are working really hard to try and deal with this, but there is a significant resource impact of that, and we have put in some requests to Welsh Government for additional funding, because I think, you know, this is all associated with the boundary change which happened 2.5 years ago. But I don't think we can underestimate the logistical and frankly cultural challenges that not yet having that issue sorted brings to the colleagues in Bridgend. You know, we still have colleagues in Bridgend who are on the Swansea Bay intranet system. We still have colleagues in Bridgend who are having to access different systems to their colleagues in other parts of the health board, and indeed it's complicating the ability to transfer patients between POW and other sites because of different pass systems. So it is a big challenge. We've put in a request to Welsh Government. We shall see whether we get any resource from that. And the second point was just to again endorse Ian's point about coding. We've had several conversations about this internally. There are massive challenges, as Ian's articulated, about coding. And coding, whilst it may not be that visible to many people in the organisation, is a really important part of what we do as an organisation. And it's really critical that we get our activity coded correctly, because not only does it make sure that we are recording actually what we're doing, it also feeds into how we measure outcomes for our patients, and also it plays into making sure that we are basing our demand and capacity planning, and therefore our IMTP and financial planning, on accurate data about what we're currently doing. If we're not recording actually what we're doing today, we're not going to be capturing that information to plan for the future either. So it is a really important programme of work, and we are actually having some conversations, and Stuart Morris, our new Director of Digital, and I have already had a chat about this and what we can do to improve further and build on the work that's already going on in the team. But yeah, just to re-emphasise, that is a really key priority for us moving forward.
Thank you for that, Paul. Thank you for that, Ian. Obviously, a number of issues raised there and a number of actions that we need to do as well from a board perspective. Any further comments? No, I've got no further comments or questions, Ian. Thank you again.
Okay, thank you.
Thank you. Can I now go on to month 7, the finance update, please, and invite Sally May to present the report which members have been asked to note.
Yeah, hello. So as you've just heard from planning, performance and finance, we have been reporting a small underspend. At month 7, that improved further to 0.47 million. I think probably what's important for me to draw people's attention to is some of the issues that are underpinning that, and some of the sort of moving parts within the overall forecast. So we've talked earlier around our planned care expenditure, and there have been a number of tranches of non-recurrent funding, in particular a further 7.8 million, which was allocated in October. So we've been doing quite a lot of work with the planned care team, Gareth and I, and my finance team, to try to understand and forecast with a degree of accuracy what our likely spend is against that whole tranche, those two tranches of funding. That is proving to be a sort of significant task. There are a number of things moving around. One is about our ability, as we've said, we've talked earlier about waiting list initiative rates, about access to private sector capacity, outsourcing, and a number of other schemes that have been delayed in terms of their implementation date. So when we looked at month 7, our sort of the risk based on our assessment is that currently there are no plans against that 7.7 million of additional funding that was allocated during October. So however, we have maintained a forecast of break even because we were in receipt of a letter from Andrew Goodall to chief executives which directed that health boards should either spend those funds for the purposes that they were originally intended, or alternatively redeploy them into system resilience. And we need to do some work around that. There has been a small change since this report was submitted, in that we've now been asked to finalise our forecast by the 30th of November, which is Tuesday, in terms of whether there is any likely underspend against those funds that therefore needs to be returned to Welsh Government, subject to an accountable officer letter. As well as some of the sort of particularly difficult forecasting within planned care, there are also issues within our unscheduled care and our winter response that we're still working through, which may affect the forecast. And the particular issues within that is recently there were some pay advisory notices issued, which could have a material impact on our expenditure patterns across both unscheduled and scheduled care, which we are assessing. Gold has approved one of those, which is the overtime rate, and we're working through the forecast over the next couple of days to look at what the impact for that will be. The other thing that is fairly material in terms of our forecast is the huge volatility in the energy market. Our estimate at this point is that despite the fact that the All Wales contracts have substantially insulated us from the effects by forward buying, we have a different arrangement at Prince Charles, which is a sort of combined heat and power PFI, and we also have around 20 to 25% of energy prices where we are exposed to the market currently. That means that there's likely to a potential cost pressure in the system, which we're managing within this forecast, of 3 to 3.5 million. The reason I want to draw people's attention to that is because that is a material issue if it continues into next year, where the forward buying isn't in place, and it's a huge impact. So that is simply 3.5 million is the impact on around 25% of our energy bills for 6 months, for 5 to 6 months of the year. So the materiality is huge. And I think also we need to consider the impact into our supply chains more generally, which is clearly quite a difficult issue. The other issues that we're currently working through in terms of our forecast is the annual leave accrual, which people will remember was a substantial increase at the close of last financial year, when members of staff were enabled to carry forward up to 20 days for up to 2 years. We are working hard with our HR colleagues to sort of finalise the position against that, so that we can maintain that provision in terms of our position. So there are a number of elements within our forecast that are quite volatile. Very careful monitoring in place, good strong working between all the different teams to monitor it, but there is a potential that we may need to return a small measure of the 8.5 million potential slippage that we're identifying here. As I say, that work needs to be returned to Welsh Government by Tuesday, which we were notified of on Monday, which was a bit of a change from the previous position. So the other things to bring to your attention substantially is the savings performance here. That again is not where we would want it to be. and even to deliver on our forecast of 13 million savings requires a step up. A straight line forecast would be at 11.4 million. So there needs to be more attention around that area, but we do very much recognise that the current service pressures do impact on people's ability to sit down and to plan and deliver transformational change, because they're working against a challenged operational background. Finally, then, I just want to talk about the underlying forecast, which has worsened in terms of our report. So at the start of the year, we were forecasting a sort of year-end underlying deficit of 31.4 million. We worsened that at month 5 to 39.3 million based on our assessment of undelivered recurrent cost improvements. We were required then to make a submission around where we thought our underlying forecast would be following month 6. We've done quite a lot of work, both bottom up and top down, to try to work through what this could be, and there are a range of potential outcomes, but our return has now moved our recurrent deficit to 50.1 million. Substantially, if you take from the 31.4, around 10 of that relates to cost improvement non-delivery, recurrent non-delivery, and the remaining balance relates to recurrent overspends that are appearing in the position. I think we've heard a little bit about some of that, but we still need to test through. So Greg has described how some of our wards now have higher staffing levels based on the assessments undertaken through his paper, but he's not yet satisfied that those are recurrent. They are nevertheless in our financial position as we at this point. So there's a lot more work to be done, but it is a significant concern that at that worsening position. But what we're trying to do very much is be very transparent about how we see the movements, how they're broken up, and to keep that dialogue with Welsh Government going. Finally, then, capital, we are expecting to spend to the revised capital resource limit, and we are in close contact again with Welsh Government around the expenditure across some very, very big programmes, particularly the PCH ground and first floor scheme. Happy to take any questions.
Thank you for that, Sally. First question in, Patsy.
Yeah, thanks. You've answered most of my questions actually. So yeah, mostly it was around the potential for an accountability letter. 2 questions remain. The impact of the November pay advisory notice, is that an increase in pay, or is it going to have the same impact as the waiting list initiative?
No, it's an increase in pay. So we had some temporary sort of exceptional arrangements in place to attract people into certain shifts. Those have now been moved to an all Wales pay advisory notice. There were 2 of them, one on overtime and one on sort of enhancements, and we've currently only adopted the overtime one, but we do think that the cost could be material, and it is likely, or we hope, that it will encourage people into more shifts, which will increase our fill rates, which is good, but it increases the expenditure as well, and that would be both in unscheduled and scheduled care. So trying to sort of forecast that through with the teams at the moment.
Okay, and then my last question that I'm not sure you've answered yet is the recurrent allocation that Gareth referred to earlier that was initially going to be non-recurrent but is actually become recurrent. Was it 26 million?
Yeah.
Would that have somehow had an impact on the underlying deficit?
We don't. We've assumed its receipt and that it offsets a number of current pressures. So if I was to report a position that included the recurrent impacts of some of the already agreed planned care recovery schemes, for example, we would worsen our underlying deficit by a further 8 million. So it's already an assumption that that £26 million is meeting some of that recurrent deficit. So there is a series of assumptions around that, and that it's for
additional services that we will expect to put in place, acknowledging how far we are from delivering on our planned care recovery requirements at this stage. I think it's probably also worth pointing out that it's a commissioner allocation of 26.1 million, so some of those funds will expect to flow to other organisations. Again, that's a piece of work that we're working on as part of our development of the IMTP for next financial year.
Okay, thanks.
Okay, thank you, Patsy. There are no further questions or comments in your report. Thanks for giving us such a comprehensive overview of the financial position and some of the challenges and risks that we're having to manage going forward, Sally. Can I now move on to 8.4, please, which is the integrated medium-term plan and development of the next 3-year plan. And I invite Linda Prosser to present the report, which members have been asked to note. Linda?
Thank you, Chair. This brief paper simply outlines the approach being taken to the next 3 years IMTP. You'll see that we have now received guidance on the 9th of November from Welsh Government setting out the priorities of the Minister and the deadlines for our submission. There is a pinch point, and it's principally around finances, as we've just heard, in that once we've received the allocations, they'll possibly late in December period to assess the affordability of the plans coming forward and make a return to Welsh Government on the 15th of January, setting out whether we think we'll be able to complete the process and submit the plan at the end of February. So we're getting onto the front foot. We're working with the ILGs and the corporate teams to set out expectations and also to start to pull in some of the benefits that we're starting to see in terms of how we could work differently through the strategy work, looking at different patient pathways where we might want to shift our investments upstream and into preventative and early interventions. I think that's probably, in the interest of time, we're expecting that. I think the difficulty will be that in the past this has been something of a bidding process and an investment process round. Given what Sally's just told us, we know that this time our attention has to be to helping our delivery units and our teams and our ILGs to reduce their costs, and there's an executive subgroup identify the processes and the support by which we help drive that to some fruition, because we're essentially looking at a process that needs to drive out at least 25 million cost savings this time round, as well as delivering on the improvements that we've talked about throughout the meeting. So it's very early, although things are going to move quite quickly. The only thing I would add is that because of the timelines, we have now, subsequent to this paper being submitted, agreed a special board meeting in February to receive the plan.
Okay, thank you, Linda. Are there any comments or questions for Linda in respect to the briefing? No? Well, we look forward to seeing the paper when it's prepared in February then. Thank you, Linda. If I could then go on to the next item, 8.5, is the Radiology Information Systems Programme update. I invite Linda Prosser to present the verbal update following discussions held at the in-committee meeting held earlier this morning.
Thank you. Yes, there was an in-committee meeting held today to take a decision on the basis of some commercial sensitivities in the paper. This is the subject is the radiology information system, which is that IT system that holds and distributes radiological images. We're in a position where our current system isn't fit for purpose, and in fact our contract in Cwmtaf Morgannwg runs out in May 2025. So and without a replacement, we wouldn't have a service. So there's an absolute need to re-provide the systems that we have. And in line with, there's a national programme across Wales to look at this, and the recommendation is to go to the market to procure a system that's designed for purpose. The process would be through a procurement dialogue with various suppliers, which would require the input of our staff being part of that and being part of the programme meetings. That in itself represents something of a risk to us, as does some of the technical and financial requirements of the case as set out in the outline business case that the board looked at today. However, the board decided that they would approve the outline business case and progression by the national programme team to proceed to the procurement and the full business case, taking on board the comments that were made by the board this morning in relation to some of the technical and financial aspects. And we will therefore be writing a letter to the national programme team to that effect, including our questions.
Okay, thank you for that, Linda. Are there any comments or questions for Linda, please? No, there are no further questions or comments, Linda. And thank you again for the report. If I can now bring in Howell for the People and Culture Committee highlight report, which members have been asked to note. Howell.
Thank you, Chair. So just for members to note, I'm delivering this in Dilys' absence. She's asked me to do so on her behalf. So just a couple of things to highlight. I won't go through the entire report, but it was a very full committee that we had, and the purpose of the People and Culture Committee is essentially to talk about all issues related to people, culture and leadership of the organisation. So we had a really good discussion with present leadership from the Bridgend Allergy on the child and adolescent mental health services, the CAM service. We also had a report on our pathways to employment work, which is really about the work that we do with our local communities to encourage employment locally, and in particular the Kickstart scheme that we are working on, which we publicised this week across the Health Board's communications channels, which is a really good scheme for us to engage with young people from across the CTM communities, and in our position as an anchor institution. Just a couple of other things to note. We are still in the process and hopefully nearing conclusion of our application to become a living wage accredited employer. We do pay the living wage as an employer, and we are currently working through the procurement process and our suppliers to ensure that our suppliers do the same, and we hope to achieve that by January 2022. And also just one or two other things to mention. We've actually approved outside of committee, which was approved, that approach was approved in committee, our new pregnancy loss policy. So this is I think we're the first organisation in Wales to do this, and one of only a handful across the UK in the NHS that now has a specific policy and leave provision for pregnancy loss. Very often that is an issue that goes hidden because of our lack of adequate leave provision for it, so it will enable us to hopefully reduce some of the stigma associated, and in doing so support our people who sadly suffer pregnancy loss. So we're quite proud of that and quite pleased to have done that, and that's something that's very close to my heart personally. So I'm very pleased to have done that for our people and made that leave provision available. And that's all I really wanted to touch on, Emrys. Thank you.
Okay, thank you for that, Howell. Are there any comments or questions for Howell, please? No? Okay, if I could go on to 9.2, the Local Partnerships Forum Highlight Report. And I invite Howell again to present the report, which members have been asked to note.
Yeah, thank you, Chair. So again, not a huge amount to go through there. I'll assume that members have read the report for the purposes of time. Just one thing again to mention. So we noted at the last local partnership forum that we had retained the Gold Corporate Health Standard Award. We've actually subsequently this month retained our Platinum Corporate Health Standard Award. Now, we know there's a huge amount to do on well-being, and we've heard quite a lot of discussions today about our well-being offering. We have an awful lot of services that are available for staff, and one of the things we're keen to do after today's board is to have further discussions just to make sure that people are fully aware of what we're providing. So what that doesn't do is give us a complacent attitude that we've cracked it, but it is a recognition that we've got a good range of services available for staff, and that satisfies the requirements of the Platinum Corporate Health Standard. So again, a positive news story for us there, but we've got some work to do just to make sure those services are equitable and fully accessed across the health board. Thank you.
Okay, thank you for that, Howell. Are there any questions or comments for Howell, please? No? Okay, thank you again for your report, Howell. I've not been notified of any other business, but if there is anything, could people raise that now? No? Okay, as you will be aware, at the end of each of our meetings, we ask a number of questions that we ask how we did in this meeting. And I just wanted to check if anyone wants to raise anything in respect to those questions, please, any pertinent points. Well, the one point I would just raise from my perspective is the, obviously there is an issue here around the internet or the computers or PC issues that we have across the piece, and I think we need to review our position in respect to that to see what those issues are, to see if there's anything else we might need to do in going forward. And similarly then, obviously in relation to in respect to a time perspective, we just might need to review our agenda as well to see if it needs to be more targeted or focused, but we can take that outside of the meeting. Okay, the next formal public meeting will be held on Thursday the 27th of January 2022 at 10 o'clock. So in relation to close the meeting, rydw i'n dod â cyfarfod o bwrdd iechyd I ben a hoffwn I ddiolch I bawb sydd wedi ymuno a ni a gwylio cyfarfod heddiw. I now bring the board meeting to a close and would like to extend thanks to all who have joined and observed the meeting today. Thank you very much.